Welcome, everybody. All right. Boy, we packed the room today. I'd like to welcome everybody to the Midwifery Advisory Council meeting. I am Carrie Sparrowan, and I chair this committee. I'd like to remind everybody now to please turn your cell phones on vibrate. If you've got your cell phone on the table or where it's going to be heard, please put it on airplane mode or turn it off. This meeting is being webcasted. And if you'd like to provide public comment, please fill out a speaker slip over here. I think they're over here, are they not? Okay. And give it to Miss Lowe right there, and then she'll give it to me, and we can get your comments. So I'm now calling this meeting to order. Ms. Lowe, would you call the roll, please?
Dr. Burns? Ms. Ehrlich?
Here.
Ms. Marcelin? Here. Ms. Webster? Ms. Jaroslawski?
Present.
Ms. Sparvan?
Here.
We have a quorum.
So the first agenda item is public comment on items that are not on the agenda. Is there anyone who would like to give public comment on items that are not listed on today's agenda? All right, seeing none, I'm going to move forward. Agenda item 3 is approval of the minutes from the December 5th, 2013 meeting.
So moved. So moved.
Thanks, Barbara. All right. Are there any comments on this agenda item from the public?
You need a second.
Oh,
You need a second first.
Or I'll second.
thanks,
Now
Karen.
you have
But I have, on page 7, it's page 7 of the packet, page 5 of the minutes. In the middle of the page, it states that I said that the challenge mechanism included the submittal of charts and that having them read by a certified nurse midwife and a physician. It is now either a certified nurse midwife or a licensed midwife and a physician.
I'm sorry, which page, Karen? 7?
7 of the packet, 5 of the minutes. And I'm surprised if indeed I left that out when I spoke at that meeting. It's
So how
right-
should it read?
It should read,
Or how did you think you read it?
what it says is included the submittal of charts and having them read by a certified nurse midwife and a physician, as well as having to take a series of clinical and skills exams.
So, or a certified nurse midwife or
Or a
LM.
licensed midwife. Now, when we originally had the first rounds of midwives coming through, it was only a certified nurse midwife.
Right, 'cause
or
there
a
weren't any
physician,
licensed
because there were no
midwives.
licensed midwives. Perhaps that's why I said that, or perhaps that was what I was referring to. I don't really remember, but I was surprised to read this as being ascribed to me.
I read it too, and I thought, well, maybe she actually said that, but I'm surprised too.
Yeah.
Okay, so the correction.
The correction would be read by a certified nurse midwife or a licensed midwife
Okay.
and a physician.
So it's an addition.
It's an addition, yes.
So-
Do you have any other edits, Karen?
Well, let me just say that the minutes of the meeting will reflect what was said.
Yeah, except they don't
But
exactly.
Something might be missing from what was said, is the point.
Yeah. Yeah.
Okay, so if it's a correction to
To the actual
what was.
truth,
Right.
current truth, can we make that addition?
You can add it to the minutes and bracket to include it.
That's not what you're saying.
Okay.
Okay.
Well, I don't know what it, I mean, I didn't hear.
I think Ms. Lowe had a solution.
Yeah. And just put it in. So I have some corrections as well that I think, I don't know. Anyway, I'd have to listen to the tape to see whether I actually said it that way, but.
What are your
So page 4 of the packet, page 2 of the minutes, third paragraph, that should be AB 1308, not SB 304 in both places there, and at the bottom of the page as well.
AB 13?
AB 1308.
I found the first 2 paragraphs to be quite confusing and wondered what the issue was. I couldn't make quite head or tails out of this.
I think that is SB 304, because isn't that the bill that had that portion, not the 1308 one?
It didn't ever have physician supervision as part of it in SB 304.
But in SB
Always-
304, it did
1308.
authorize certified nurse midwives to supervise students.
That's the only one. That's the only thing where it's correct, is that first paragraph. And then all the rest of it, it looks like whoever transcribed it just kept putting in SB 304 instead of AB 1308. Maybe they couldn't understand the
Okay, so
tape. I don't know.
without the value judgment, what's the correction?
The correction would be in paragraph
3.
3. SB 304 should be struck and AB 1308 should be put in those two places. And then in the last paragraph on that page, the same thing. SB 304 should be struck and AB 1308 should be entered.
Okay. And in paragraph 2, it's to be left as is, SB 304?
Yes.
Thank you.
And then it carries over as well to page 3 of the minutes. Second paragraph there, we're still on SB 304. It should be AB 1308.
Right.
I had a bunch of corrections, but on page 9 of the minutes, page 11 in the handbook, the third paragraph down, I'm not understanding that, and I'm just wondering if anybody else is not understanding it or if I'm the dense one, but that first sentence there,
Please read it.
Ms. Lowe stated that the board was in the process of hiring behind the previous midwifery analyst.
Would it be to replace?
I don't know what that's I don't know what the sentence really is there. I think perhaps it was that Ms. Lowe stated that the board was in the process of hiring a new midwifery analyst.
I think it's just a technical thing that they're hiring behind someone, not behind someone's behind. It's just in place of, on the scale of hiring, they hire behind a position. So next in line. So maybe,
Okay. It just didn't make sense to this layperson here. All right. If it makes sense to everybody else, I'm fine with it.
I think we understand what was intended to be meant.
I did. I just thought there was maybe a typo in how the sentence was composed. On page 13 of the minutes, page 15 in our book, the second paragraph from the bottom, third line up, it's a public safety issue if you have a mother and a baby, and it currently reads, who needs attention at the same time as two sets of hands may be needed. That should probably be who both need attention at the same time. And on page 16, the following page, paragraph 3 from the top, third sentence down, does not require a licensee. I think that should be license, but maybe I'm wrong. The licensed midwife, a bona fide. I'm talking about, yeah. Ms. Webb stated that there are 3 avenues right now to be involved in the practice of midwifery: the licensed midwife, a bona fide student, or someone who is doing something that does not require a licensee. I think that should be license. And then how that plays out can be found in case law in part. She suggested looking at the Boland case. That should be Boland, B-O-W-L-A-N-D. And let's see, and that's all the corrections I have. Does anybody else have corrections?
There are some other spelling things, but I actually did not have the minutes in
I'm
time
going to
to go
suggest
through
that
these.
maybe it's appropriate that the minutes be run by the chair prior to being printed in the future. It might make our reading of the minutes more understood.
Works for me. Do you have any public comment on this agenda item? You want to come forward, sir?
I lost the page. There's reference to Ms. Davis, and just to clarify that it was Rosanna Davis, but she's not listed as
An attendee.
as an attendee, and I am, so Rosanna Davis should be added as an attendee.
Okay, and then how are we gonna, where in the minutes are we gonna note that it was Rosanna and not Sarah?
I don't know how they usually do that.
Yeah.
What are you referring to, which paragraph or agenda item? On page 13, there's some.
Yeah, page 13 of the packet.
Oh, okay. So all of the Miss Davis on that page is Rosanna, not Sarah. Okay. All right. Is there any other public comment on this agenda item? Any other comment from the council? All right. Can we accept the minutes then as amended
With corrections, yes.
with the corrections? All in favor?
Aye.
Aye. All right, so moved.
Did everyone vote? Any opposed?
Any opposed, any abstentions?
I'm going to apologize now for the on and off of the glasses. My regular ones are driving me crazy today, and I can only see with the cheaters, but I can't see any of you with them on, so that's why they keep coming off and on. All right. So this next agenda item is my report. I just want to say that as we begin the 2014 MAC year, I'm really excited to be a continuing member of this team, working with all of you and our public constituents in the forging of a new era of midwifery in California. There's much work to be done both within the council and the medical board to bring about the changes that are dictated by the new law, while creating an atmosphere of respect and mutual collaboration between the disciplines of medicine and midwifery. With the removal of physician supervision from the Licensed Midwifery Practice Act, along with other important changes brought by the passage of AB 1308, there are new opportunities for creating relationships between physicians and midwives, bringing potential benefits to the birthing families of California. I sincerely hope that the new relationships forged between midwives and physicians and hospitals will be ones of mutual respect, with a common commitment to the creation of safe and respectful healthcare venues and policies for California's women and families. I'd like to take this opportunity to reach out to licensed midwives throughout the state and ask all of you to work within the provisions of our law to make the changes that will benefit birthing families in California. Please recognize that the actions of any one of us reflect on all of us and make movement in a positive direction, can make movement in a positive direction more difficult. Please work hard in your communities to provide the help desired by unlicensed midwives to become licensed, and consider your own abilities to precept students in your area. Work to create networks within your communities of care providers who will provide options to women that are often difficult to obtain, while refraining from providing care that is outside your lawful scope of practice. Work with consumer-based organizations such as California Families for Access to Midwives and International Cesarean Awareness Network to legislate changes to current law where it is necessary and desired by women. Share the networking and relationship building skills you develop in your communities through your state organization, the California Association of Midwives, in workshops and peer review groups and online blogs and any other way you can think of, so that we can all gain insights into how to create these new pathways for interactions between the professions of midwifery and medicine. I ask all of those listening who care for women and babies, both midwives and doctors and families, to work together as you've never done before. Together, we can make the changes that serve women and families and make the transition to life for babies as optimal as possible. Thank you. Have any public comment on that agenda item? Any comment from the council? Okay.
Bravo.
Thank you. Thank you. So seeing none, let's move forward to the Midwifery Assistance Task Force. So as most of you know, in order for midwifery assistance to be accepted and allowed by law, we will need to get language and statute that supports it, because there isn't any right now. To that end, I'm going to appoint a task force of myself and Dr. Byrne. He's not here, and I'm not really nominating him in absentia. I spoke
That's
to
a
him.
good idea. You don't show up, you get nominated.
Exactly. I did speak to him, and he is willing to work with me to go through the myriad of options to creating a legislative proposal that could move forward next year. I know that there are many people that would like to work on this, and I'm limiting it to 2 people so that we can actually get it done, because there isn't staff time to monitor it if we have more than 2. And I expect to have a report back to the MAC at the August meeting, and we can have a lot of discussion around it at that time. Any discussion or questions from members of the council? Okay. Any comments from the public? All right. Seeing none, we're going to go on. So Dr. Byrne was going to present on the next agenda item and asked me to present in his absence. The California Association of Midwives and the California Nurse Midwives Association came up with a kind of a comparison chart. It looks like this, and it's either at the back or on the side somewhere if you don't have a packet or you don't have a copy of it. This is the initial draft. I edited some of the language, and they took my edits, but we didn't get it printed properly, so we don't have the actual handout for you there. I'm not sure we need to go into it in depth here. My edits really were more referred back to statute in terms of what the requirements were for licensed midwives, what our scope of practice was, what prescriptive authority looked like, and practice settings and education. And I'm wondering if there's any public comment on this agenda item. Any comments from council members?
I think this is very helpful, actually.
Yeah, this is a step towards creating something that we can give new board members as they come onto the board, so that they have some kind of an idea of the similarities and the differences between licensed midwives and certified nurse midwives, because I think most healthcare providers are pretty familiar with certified nurse midwives and what they can and can't do, and much less familiar with licensed midwives and what our role is in the healthcare picture. Faith Gibson, did you have anything to add to this? Because I know you were working, this was your task force with Dr. Byrne, but he didn't know whether you had anything to add.
He and I were not able to meet.
Please come up and use the microphone.
How quickly we forget. Faith Gibson. Dr. Burns and I were not able to meet together, and so it really kind of remains in limbo. I did put together information that's still on the internet that has to do with kind of the big picture, the history, those kinds of things, and I'm happy to write a smaller version of that if anyone is still interested. But at this point, he and I don't have anything going relative to this.
Thank you. Any other comments or from the council or the public?
I would just like to have, hopefully, perhaps to follow up on this at the next meeting, so that we can have a chance to absorb it and see if
Yeah.
we want to make suggestions.
I think that's a great idea, and we'll get a corrected version that's situated properly on the page, so you can actually see the edits. All right. So seeing no further comments, I'm going to move on to the next agenda item. Karen, would you give us your update on the
Yes, I'd be happy
statistical
to.
comparison that you're doing?
It actually, this should be titled the Licensed Midwife Annual Report Statistical Comparison. It should not be anything with the Midwives Alliance, because this has nothing to do with the Midwives Alliance. It did not come through that at all. This is a summary of the 6 years that we so far have licensed midwife annual reporting done via OSHPD that I have put together so that we have a full overview of all of these 6 years. On the table outside, there is this page. The title is Outcomes of Planned Out-of-Hospital Births with Licensed Midwives. It is supposed to be page 2 of the full report. Page 1 being the page that says Licensed Midwife Annual Report 2007 to 2012 Overview Summary. Then this Outcomes page is supposed to be number 2, page 2, and then the reasons for hospital transfer are the next 4 pages, I think that is.
Okay,
But
so the outcomes page I'm not seeing in our
it is not there
handbook.
because there
Okay.
was a glitch with email and computerdom. It's on the table
Okay.
outside. But this is actually the one that I want to spend the most time with because of what you will see at the bottom of the page. When we are talking about fetal demise, I think my impression is that we need to have this, first of all, better defined in the instructions and in the definitions as midwives make this report, if we are going to stay with the OSHPD reporting form. From what I can gather, as I read the instructions and the reports, is that that is fetal deaths from 20 weeks through labor. And I think that we need to define it better. We need to understand fetal deaths up to onset of labor, and then fetal deaths during labor through to the immediate neonatal period, and then neonatal deaths following the immediate neonatal period. We have to have those broken down, or we will never understand how many newborns are actually not surviving birth out of hospital in the hands of licensed midwives. Because if you look at the numbers, what you'll see when we then go to fetal demise diagnosed prior to labor, and fetal demise diagnosed during labor or at delivery, and live-born infant who subsequently died, none of the numbers add up. Nothing equals anything else. So we really do not know what kind of perinatal death rate we have in California for licensed midwives and out-of-hospital births. One thing that I started to ask for a couple of years ago of OSHPD that has never gone anywhere, and I'm going to renew this request, is that the form, the electronic format be changed so that in Section E, when we are first asked to list how many births we have done and in which county, how many fetal demises there are, how many maternal deaths there are, that as soon as a midwife enters a number in that column, there is an immediate, I don't remember the technical term for it, an immediate pop-up that says, you have listed one fetal demise. Please explain exact gestational age. Was this prior to labor? What is the reason for this death, if it is known? So that the streaming comes from the very first time that any death is reported, and we do not have a possibility of having double or triple entries in order that we can really begin to have some accurate numbers. These numbers clearly in the fetal and perinatal deaths are not accurate. So we can't tell anybody how well or poorly we are doing. It's a guesswork, and I don't think that this is okay. I think that it's not okay for the medical board to be reporting ambiguous information, and it's not okay for OSHPD to be gathering ambiguous information.
Karen, could
Yeah.
part of that solution be a line that was total number of fetuses, infants who died during your care after 20 weeks gestation that would add up to the rest of the total somehow?
After 20 weeks of gestation, up to onset of labor has to be one category.
No, you could have the individual categories, but then what I'm saying is to have, like here, this final line is perinatal neonatal mortality, which is 4, which for the 2012 year, which doesn't add up
With anything.
with any of the rest of this. And I'm wondering if we could have a box that did add up to these individual things.
If,
So that-
when the first time a midwife enters a death, there's an immediate pop-up that then the computer does the entry into Section O or Section P, I believe we have a much better chance of actually having numbers that add up.
So what would be your recommendation at this point in trying to get this fixed?
My recommendation for starters is to involve OSHPD in revisions of this form so that nobody can ever enter a death more than once,
Okay,
Can I,
anywhere in the questions.
yeah.
I'm going to chime
Natalie?
in here for just a minute. So later, as I provide an update on some different regulation changes that we'll be doing for the board, this is going to be part of it, and that adding and deleting possibly data elements from the report. But part of it also is that we do have the ability to edit the form, to add clarifying text on what needs to be entered, and we've mentioned that before. Staff here, our IT department, we can discuss the options of adding prompting fields that if you enter, enter any data, that it prompts you to enter another data element to match. So we can take that back and discuss it with our IT department and see if that is an option, since we do have a little control of it.
Right.
And then we'll also need to be in discussion with OSHPD, though, and
I understand that. I would like to emphasize, I've been asking for this for at least 3 years.
Yeah, I think that it would be really helpful to have Karen present when they begin to craft whatever pop-up boxes need to happen, since she seems to be the one that's most familiar with where the discrepancies are, so that we actually get it right,
okay. So
or as right as possible.
one of the things I will be discussing is an interested parties meeting to go over these specific items. And, at the interested parties meeting, not only would Karen be available to
I
provide
will.
input, but also
Yes.
the rest of the midwifery community that's providing that data. We would like their feedback, and we can take it from there to actually possibly change the regulations or laws regarding the reporting.
Okay. Well, I don't think we need to change any regulation to add stuff. Am I
don't want
correct?
more- you don't
To
want more
add
laws.
clarifiers or other things like that. If we're not actually changing, we're not deleting any of the information that the law has asked us to gather, but we're simply clarifying some of the information that the law has asked us to gather. We don't need to change a regulation for that, do we?
I think we probably will need to change a regulation to provide clarification. And if we're going to add or delete data elements, that would be a statutory change.
Right. Adding them, I think we've been given permission by AB 1308. Deleting them, no. But,
We've been authorized to adjust,
yeah.
and adjust means up or down.
Yeah, well, let's
think
not
what
beat
you
that
need
dead
to-
horse, but basically what I'm saying, Carrie, is that we're not asking to stop collecting any of the data that the law has required us to collect. And there's nothing in regulation that created the current LMAR. It was something that was created in this council, and it's not a regulation at all. It's strictly based off statute. And we created it as we went along, and it's an imperfect tool. And so now we want to make some changes to the imperfect tool that we originally created in this body. I don't think that requires regulation, does it? If we're not going to remove any data sets.
I think what we'd have to do, though, is whatever you're adding as a clarifier, we need to make sure that that is in line with the statute and in line with any existing regulation. I think
Right.
that's what Carrie was trying to get at.
Okay.
That's,
I get
yes.
it then.
Yeah.
Yeah, I would expect that. But what I was trying to avoid was going through a whole bunch of regulatory hearings and stuff. We didn't have to.
So, Ms. Sparrow.
Yes.
So I think that what we also have to be cognizant of is the fact that the people that are reading the report and the people making the report are coming from two different viewpoints. And the problem with this is that what is sounding clear to you is not sounding clear to them, and what's
Right.
sounding clear to them is not making any sense here. Because the numbers, in fact, do add up. They do, if you know what you're looking at. If you don't know what you're looking at,
But they don't, Barbara.
They
They
don't.
don't.
No,
They don't,
they don't.
and they never have.
But wait, so if, I know, but if you suggest that fetal demise is something that dies, and the question is that they've died, at what point have they died? And at the end of the day, they've still died. The numbers that you're adding up at fetal demise diagnosed prior to labor, that means the end of the delivery, correct?
That means before labor starts.
Prior to labor is before.
End
labor.
of a pregnancy.
End of the pregnancy, yes.
You're still at the end of labor, and at the end of the birthing process, it's the same person that's died, or the same entity that's died.
But unfortunately.
They're
the-
called different things.
They're called, so
called
that's where,
different
that's what, so the clarification then needs to be, so the totals need to be at the end of the discussion and not during the discussion. The other issue I wanted to ask you about is when is this data posted? So when does a licensed midwife fill out the forms? And is there a time constraint so that therefore the one answer at the end of the day would be the same answer because of the way that, the timing of the framework of the question? So that if you were answering the question at the time of the incident, you only can answer the question once. You can't answer it more than once, because two answers are not going to work. The form won't allow you to do it.
But the
So
form does allow you to do it, is the problem.
That's where,
Yeah.
okay, so that's what
That's
needs
the
to be.
issue.
Okay, that's
Is
what
that there
needs.
are several places where you could enter the same data. That's
So
the
that's,
problem.
the problem is that everybody is entering, the same person entering data in multiple locations.
Well, on
and
their
then-
form, but it's asked for in different places on the form.
But
in
that's.
different ways.
But that may, so
ways.
the issue is you're asking different ways because you're trying to get different information? The answer is no, you're trying to get
Right.
the same information. Maybe you don't have to ask it so many.
Here's an example, Barbara. The last two lines here, live-born infant who subsequently died and complications leading to infant mortality. One is section O, one is section P. Complications leading to infant mortality could be the same infant
Exactly.
who was
That's-
live-born and subsequently died.
That's my whole point, that it's being counted, double counted.
Exactly, that's the problem.
And that's what our concern
Where
is.
the problem is. Mr. Bruce Ackerman?
If I can just comment as somebody who struggled with this because I'm not very good at computers, and I filled out for as many years as I could the whole thing on paper, which is no longer apparently allowed. I just want to say thank you to whoever made the form easier over the years.
Yeah.
It has improved.
That's
Just not enough.
not enough.
Right.
And,
It's a
and the
work in progress.
and so when you're getting someone to look at how to improve this, grab some new midwife who has I've also helped other people figure this out as I've added people to our practice, but so I'm
Get somebody who's never done it before.
Yeah, get somebody who's never done it before and somebody who may not be
That
really
could be
good
me.
at computers.
That could be me this year.
And give them the job of,
Yes.
testing this, because
Yes.
it's not always as easy as those of us who make things happen easily would imagine.
That makes sense.
Thank you. Bruce?
Bruce Ackerman, representing the Midwives Alliance Division of Research. We do data collection quite a bit. And so just a couple of comments just intended to be possibly helpful. One thing is that we certainly have discovered that with rare events such as demises, that every one of them has its own unique story. And to have a data form on which we can expect midwives to tell that story by figuring out where on the data form to put what and understand all of the terminology that is used in the research world or the public policy world to distinguish these different events when actually the story was ambiguous and very, very unique in itself. That's not the way to go about it. And so what we do is we actually have a trained team of people who interview a midwife whenever she reports a form that includes a demise, other than a miscarriage. And through that process, we make sure we get it clear and we get classifications that are made by someone who has gone through a training program and understood what those classifications are intended to mean. So we get really good, clear data that way. Now we do collect data, individual birth data, and that's different from here, and that's one of the areas that the LMAR faces a difficulty in that you're asking midwives to give you aggregate data for their year and not individual data for each individual birth. The other area in which the LMAR faces difficulty is that by statute, and I think this is what you intended and therefore the right thing for the statute to say, but by statute, there is nobody, OSHPED or anybody else, who is able to go back to a midwife and say, well, we received your report, but some of these numbers don't add up, and we wanted to talk with you about that and figure out what's wrong and get them to, make sure that they add up. That's what we do with our data review, not only with demises, but with many other things. Our software has a huge number of different things it looks for. If there was a C-section reported, but the place of birth was at home, then that would raise a flag for the midwife. She would be expected to either explain that flag or correct it, and if she explained it and said, yeah, this is correct, and submitted the form, then it goes to data review, and a reviewer would then, no doubt, contact her and say, I still don't really understand, how could this have happened? And maybe there is an explanation. Maybe the woman happens to live in the hospital or whatever, but, it would be a rare circumstance, and therefore we have our software set up working with the reviewers, so it's a combination of software and human interface and actual communication back with the midwives. And that's what it takes to get really clean data. It's just really phenomenally difficult. And we need to make sure that we're not implying that the midwives are somehow have more difficulty than other people might have in filling out forms. It's absolutely universal. Happens to everybody.
Yeah.
The DMV could tell you the same thing. I used to do registration for a conference. We had the same issue. It's just really difficult.
I appreciate your stating that, Bruce, and I still think that if we can take this particular step that I've been suggesting for a couple of years now, that it would help us to get better data.
Well, I would agree with that as well. I mean, our data form also branches very carefully. So you don't get presented with a question unless it's relevant. And so you answer one question, and then possibly you get presented with another question, but not with a different question, and that's all. That's all part of the thing, and that's it takes a lot of sophistication to do that. And so again, it seems to me from watching this process that the LMAR process again has another difficulty in that the cycle within the governmental process by which we can look at something, say, well, this ought to be changed, and then by the time it actually gets to where it's actually changed on the ground and actual midwives are actually seeing a new form, there's a long cycle, which appears to be more than a year. So you can actually have the form coming out next year being already the one that you're pulling your hair out and saying that's not the one we wanted, but the cycle takes longer than that.
You're
so
absolutely
you've got
correct.
a lot of obstacles to deal with.
I appreciate your insight that the LMAR is asking for aggregate data instead of patient-by-patient data, and I I knew that, but I hadn't really incorporated it before, and that would really lend itself to this kind of an error, because you're not, you had, a demise in your practice, but you're not entering the demise at the same time that you're entering whatever caused the demise. And so that's an issue. Thank you.
Yeah.
So my understanding is that this is something that is going to be functioning, being worked on within a task force or work group. Okay.
Do you have a time frame for that, Natalie?
Sometime between April and August.
Okay, so before the next MAC meeting? Perfect.
Will it be done in time so that the 2014 data questionnaire will be updated? Or are we going to have yet another year where numbers don't add up?
Depending on what the outcome of the interested parties meeting and what we are actually going to be wanting to move forward with, we don't know. I can't tell you yes or no. Hopefully, that'd be nice, but.
So that's a hoped for goal.
Yes.
Okay, thank you.
Are there any more questions or comments from council members? Any additional public comment on this agenda item?
I actually do have just a little bit more to state.
Sorry, Karen.
Oh, it's okay, I forgot. Until you asked for more comment, it's like,
All
but
right.
I'm not done.
Then.
On the reasons for hospital transfer, I have included here most of the reasons that midwives wrote in for why they transferred a mother and/or a baby. There were a few exceptions that there were only one or two items. I wanted to make sure these fit on the page, so I did not 100% put in every single reason. What is interesting as I looked through these and ran the numbers and ran the entering into my database is really the only number that is not consistent with other numbers in its category is in 2007 in the antepartum elective section, where the client request is 160 in 2007 and only 26, 32, 37, 39, and 40 over the next 5 years. And I'm not sure we ever really quite figured out why that number was so large in that 1 year. But it was the first year that we had ever had the reporting. And it may just have been some level of misunderstanding that we did do some clarifying on the forms as we went along, and perhaps that helped. But throughout the rest of this document that I put together, the numbers are remarkably consistent overall. And epidemiologists whom I've spoken with about this have said that when you've got consistent numbers over a great number of years, that it helps to validate that information. So with all that we do not have clear and, I think, reliable information around fetal or neonatal demises, in terms of the numbers, the reasons why we transfer, I think that is pretty accurate. And in this overall summary that is handed out separately, the outcomes of planned out-of-hospital births with licensed midwives, the percentages are pretty consistent as well. The percentages of births that are completed out of hospital range between 81 and 85%. And that's pretty accurate, pretty close to each other. The percentages of intrapartum transfers over those years range between 17 and 20%. That's pretty close. The percentages of newborn transfers range between 2% and 2.6%. Those are pretty close. So I think that we're doing well on gathering the information for those categories, despite the fact that the form is what it is.
Yeah.
Just take 2011, where there's 20.6% or intrapartum, plus postpartum. Okay,
Yes.
never mind. I couldn't see 111.
Right. No, I decided to combine those because they're really hard to separate out anyway.
Okay, I get it, thanks.
All the same event.
All right. Any other comments from council members or the public? All right. Seeing none, I'm going to move on to the next agenda item. So there's an update on implementation of Assembly Bill 1308. Ms. Lowe?
Okay, so we'll start with agenda item 8A, which is the transfer of planned out-of-hospital delivery to hospital reporting form. Due to AB 1308, Section 2510 of the Business and Professions Code section was added requiring the board to create a form to be utilized by hospitals for reporting each transfer of a planned out-of-hospital birth. The form that was created has been provided for you on page 24 of your packets. And prior to finalizing the form, input was obtained from outside sources, including CAM, ACOG, CMA, California Hospital Association, and other hospitals within the state. Feedback obtained included requests for additional data elements to be reported, and the most recent request was to change the wording healthcare provider to physician. However, because the form was created without regulations in place, we are only able to request items on the form that are documented in statutory or in the law. So in order for us to add additional data elements, we'll need to go through the regulatory process. And the form that has been provided is our finalized version of it, which will be posted to the board's website following today's meeting and also sent out to the hospitals.
A question for you, Natalie. When you say that it is finalized, who did the finalizing? Was it all staff? Were there board members who were involved? Were there council members who were involved?
The form was created by board staff and legal counsel, and then, as mentioned, it was sent out for some outside input from the powers that be.
Okay, so is it time for other questions, Carrie?
Are you finished with
That's all I
this
have for
particular-
that item,
Sure.
yes.
Go ahead, Karen.
Okay. It is interesting to me that name of the healthcare provider. The name of the mother is or isn't on this form.
It's only on the second page.
Is that a HIPAA violation?
The reason that the forms were submitted or separated into two different documents and only listing the mother's name on the second page is because half of the data has to get submitted to the California Maternal Quality Care Collaborative, and that information is not provided.
So the mother's name will go to the medical board, but will not to the Quality Care Collaborative?
Yes. The medical board has authority to request a patient's name through HIPAA, right?
And records.
And records, yeah, okay.
Is that true when there are no cases that have come to the medical board?
I mean, if there's not a complaint?
There's not a complaint to the medical board? The medical board still has the right to get records
there would be
for
no
just
reason-
a fishing expedition?
The medical board has no reason to go for fishing expeditions, no. I mean, they don't, we don't.
And they are dictated by statute to create the form.
I understand that. I'm just, I'm
So your concern
surprised.
is having the mother's name on a form, is that what your concern is?
Yeah, I am.
I would venture to say that if it were a situation where there was a complaint going to be filed, that medical records need to be obtained,
Absolutely.
expert witnesses need to be retained.
Yes.
And someone has got to be accountable for the complaint. So that if you complain about her service, and she is also a patient, there needs to be more than one, there would need to be more than one gathering of records.
But that's if there's a complaint.
Right, but
This
there's-
is simply a report of an event that happened that might well have no complaint behind it whatsoever.
I don't know, but it's not going
Maybe
to
we
be
could
sitting on the
just
front
ask-
page of a newspaper.
Maybe we could, I assume legal's
is-
already weighed in on this as to whether or not it can legally be done under HIPAA?
I think the form is appropriate.
Thank you.
Okay?
Any other comments on this, on the form? Sarah Davis?
Sarah Davis with California Association of Midwives. I just have a question. Ms. Lowe, you said that only data elements that are in statute could be on here, and I'm wondering about the checkbox for licensed midwife arrived with patient. That's not in statute. I'm wondering if there's a benefit to having it on here, considering it's not in statute. Not necessarily opposed to it either, just reflecting what you said.
I would have to look into that to see if it was based on one of the comments provided by the outside sources, if it was added or not included originally and was requested, so I can follow up with that at the next MAC meeting. But actually, it would be prior to the MAC.
Also, I think it goes to the licensed midwife shall provide records, including prenatal records, and speak with the receiving physician and surgeon. And so it's a way to check to see how that process went.
But
Obviously, if she's not there.
she could be speaking to the physician by phone
And fax the records.
and fax the records.
So how that information is gathered is part of this.
But the
Okay.
question,
But
I guess
wait,
so.
wait. So
I
then-
appreciate it as a data point, and I think it's useful. But just that it was just reflecting what Ms. Lowe said, that since the statute doesn't actually require that the midwife arrive with the patient, I was just wondering about this being on here.
So let me ask you the question, because it's starting to feel to me like we're starting to push it at places that maybe it's not going to benefit in the long run. And my concern is this, that when, if God forbid something wrong happens or something needs to be verified or checked out, you need as much information, much data as you can collect to either make that the incident had no relevance or the incident did have relevance. And the object of having to go looking for and searching for and taking time for and not moving things forward in a timely fashion doesn't benefit either the parent or the midwife or the hospital or anyone. So, I mean, I'm not sure why we're looking to, the spirit of the situation here is that we need the information. The spirit of the situation is that we need the best information that we can acquire. We can't acquire it if we don't have a name of a person we're talking to, and we can't acquire it if we don't know the circumstances. So I understand that you're not doing it because you agree or disagree, but I'm not so sure why I understand crossing Ts and dotting Is, I understand.
I can give
that.
a little more clarification. So it is required by statute that the licensed midwife call in to report the transfer. And it's required that she provide the records, but it's not required that she arrive. So I
Nobody
just want it
says
to be
but
clear that this isn't going to be used punitively
No,
for
but
someone
nobody
who
is saying
checks
that you
no.
have to arrive. The question is, did she or didn't she? That's all the question is. So I think that we have to be careful not to read into stuff that doesn't exist, and we're not looking to fish. And by the same token, we're not looking to be fished with, I think. So I think in the spirit of this,
Yeah. This,
Take a deep breath.
this form had a lot of back and forth with interested parties group to create it. And it pretty accurately, I think, reflects what that group came up with. One thing that's not on the form, and I'm wondering why it ended up not being on the form, was the name of the physician that the midwife gave the report to, which may be different than the healthcare provider who assumed care. Because the healthcare provider that assumed care could potentially be a certified nurse midwife, or a registered nurse initially, or somebody in the emergency room. And then we have a way to track who the midwife was, but we don't have any way to track who the physician was who took the report from the midwife, which I think might be a really valuable piece if we have to gather more information at some point.
And
so there's no signature on this piece of paper, and you're suggesting there needs to be a signature on this piece
No,
of paper?
I just think that there should be, while there's a place to put the name of the midwife and her license number, there should also be a place to put the name of the physician who took the transfer and his license number.
You have the name of healthcare provider assuming care.
That could be a nurse, it could be a nurse practitioner, it could be a certified nurse midwife. It may not be the physician that's dictated by law to take the report from the midwife.
So that's why I'm asking, do you think you need a signature here?
Not a signature, we just need his name and his license number, like we have for the midwife. And like we have for the person who's assuming the initial care. Because you might come in with your patient, with your client, and the charge nurse begins to get her admitted before the physician shows up. So that would be this person and their license number. And then the physician has to take a report from the licensed midwife. We need to have his name also.
We can add that to the form and just make a statement that if different from above, include that name.
Right.
I like it.
Yeah.
Yeah, perfect.
I would also like to see on that page where the mother's name does appear, that page needs to state clearly on the page, this page should only be sent to the Medical Board of California. Do not include it in the report that goes to the California Maternal Quality of Care Collaborative.
Yeah.
Because the fact that it's separate, the instructions are in one place and that particular page is somewhere else, I can well imagine a busy healthcare clerk, nurse, anybody, just sending it along with the form and not even noticing that it isn't supposed to go.
Yeah. It would also be good to have some way to link page 2 to page 1. I don't know. I don't have a good suggestion for how to do that, but so that, if it got to the medical board and it got separated, who that patient name, which form did it go to? And it got matched up properly.
Like a unique identifier number?
Yeah, or something.
I guess I'm
I don't
going
know how to do
to
it.
raise the question that Karen did again, and why anybody needs to know the patient's name. And if they do I have to, as the transferring midwife, alert the patient that I'm transferring that their name by entering the hospital is going to go on a form that goes to the medical board? There's a lot of people out there with privacy issues, and HIPAA's made to protect people, but we know how far that really goes, which is not very far.
I would
You want to
suggest
send this back to staff and ask them to come up with an opinion?
Yeah, and I would also suggest that there needs to be some way, whether we use a patient name or not, there has to be some way, if we need to gather more information about that transfer, not in a punitive way, but to see, gosh, this looked like it went really wrong, how could we make it better, to have access to the patient's full medical record. And we can't do that if we don't know who the patient was.
Just ask the midwife. Her name's on there. The physician's on there.
Yeah, I think it could be.
I mean, we're not going to none of us does so many transfers that we're not going to know who they're talking about.
Right.
If they say the hospital name, the date of admission, the doctor you talked to.
At this point, I just wanted to let everybody know, I think that's a great edit to add in the physician name down there, and I don't think we'll have a problem if it's different than the individual up above who's assuming the care. One other edit that we're going to add is because we have the healthcare provider assuming care, and it was a good catch to keep those separate because the law does specifically talk about your talk to a physician. So we're going to do the type of license. Those are the edits that we're going to make to the form. Legal counsel has reviewed this form, and we're going to be sending this out probably tomorrow or Monday.
And with no notice on page 2 that this page is not to be sent to the California
It is.
Maternal-
It's actually up at the front, and we'll make sure that when we send this out, that it's very clear that.
It's not clear if it doesn't appear on the page that is not to be sent.
Okay, we'll add that in, Karen, then, too.
I think
that
that's
please
really
do not send
important.
this. That's fine. We'll
Yeah.
add that in there, too.
It's not,
Yep,
please do
that's a
not
good
send.
idea.
This
Thank you.
form should.
Yeah, do not send this page.
To be submitted to the medical board only.
Yes, yeah.
All right. Thank you. Do I have any more public comment or?
Yes, you do, Dr. Bear.
So,
Welcome.
hello. I've been involved in the process, and just to go back to legislative intent of this form, the law states that the medical board shall create this form, and I think it's a fine, bare bones attempt for what we need to get out there right now because it started on January 1st.
Right.
But it really doesn't reflect the legislative intent when we created the law. The law was we remove physician supervision, we gather data, and we meant for that to be a more substantial form because we're sending it to the CMQCC, which stands for California Maternal Quality Care Collaborative, not just for a name and a name and a name,
Right.
but really for outcomes. We had a pretty good working group going before this with I felt like all the stakeholders. We were probably missing the medical board, but probably by statute they weren't allowed to be there.
Right.
But we had, we had the CMQCC representative, we had ACOG there, we had midwives there, we had L&D nurses that would probably be filling out these forms. And I thought we were darn close to almost perfection, and we got a little derailed. So I would ask that this is a fine, bare bones attempt to go on the website now because we need something now, but that we form a working group that really fulfills what the legislative intent of this form was.
Thank you. I appreciate that.
We're agreeable to that. We can't even get to the legislative intent if the wording in the statute is clear. We have to go based on that. And if we're going to require entities to use the form, we can only do that through a regulation. So we're putting, like you said, the bare bones form out there. We're interested in gathering the additional data points as well, and that will come.
Okay, so our next step would be a motion to make that working group for the regulation at this point, or?
I think it's gonna come down the line.
But I think you also need to keep in perspective that, given that this is a bare bones, let's see how it goes for a while, for a specific amount of time, 6 months, 3 months, whatever it is, 9 months, and see what changes need to be put in so that we don't keep changing and changing. Let's try and make the change really be meaningful and impactful and be in the spirit of what was trying to be attempted. Because it's a little fix, nothing is fixed.
Right.
Yeah, I would really encourage the work group that was in place to continue to do some more work on it and get a real nice formalized version of your wish list of what we'd really like to see collected. And then we'll have something to come back and do
Right.
regular.
And we already
regulations.
have that, so whenever the working group would like to get going, that would be fine.
Okay. Super, thank you. Anyone else?
Hi, I'm Teresa Mclean with California Families for Access to Midwives, and when the working group begins again, I'd like consumers to be one of the stakeholders at the table and be part of the process, which we weren't really. And since the names of the consumers are going to be on the form in one way or another, I think it's important that they be included in that working group. Thank you.
That's really important. My vision of how this will move forward, correct me if I'm wrong, Ms. Webb, is that it will move forward like with an interested parties meeting where things will be presented and hashed out, and then regulation will be crafted and move forward in that direction. Am I right?
That's right, and I anticipate that the California Hospital Association would be a big part of that because
Right.
they have concerns.
They also
about the
didn't really
burden
work on this.
completing the form.
Right. So there'll be lots of time down the road to make more comments. Ms. Gibson?
Faith Gibson, California College of Midwives. I have one question, which I recently had an emergent transfer just 7 days ago today. And the concept of provide medical records, is that assuming that I'm going to come preloaded with Xerox copies? I had the medical records. They did not see, the hospital was not interested in copying them. So how it, in other words, they had access. I would put in the word access if I were being a, real tight definition. I provided access to the medical records for which they were welcome to Xerox, but didn't. The other issue, which in the last couple of transports that I've had, included, at least in these instances, physicians who really didn't actually want to talk to me about it. And so I have some concern about the reason for transfer part of this, and I'm assuming this would be something we would address in the regulatory process, but that the licensed midwife would be able to read it at the time or have access to it afterward to be sure that it was actually real. That, in other words, that it was accurate. That someone did not mistake the concept, or the idea that someone's water was broken for 40 minutes with it that had been broken for 40 hours, which makes a huge difference if you're talking about legal culpability. I also, just since we're asking, or I'm the one that's doing the asking here, I'd like to ask the possibility that the midwife's name also be on that second page, so that the information that went to the collaborative, the California Collaborative, which is an NGO, it's not a regulatory agency, had the information about the birth, the statistical part of it, but not the name and license number of the midwife any more than the name and address of the mother. I think that's it. Also, if anyone here is interested, this is my wish list. And what I did was to put it in the form of that the midwife herself would fill it out and put it on the patient's chart that would have what I would call kind of the forensic information if you're trying to get information in a big hurry, or go back later and figure out what happened. Either one. Thank you.
Can I ask you a question,
Yes.
Faith? So you're also saying, in essence, that any midwife who makes a transfer of care to a hospital should really have one of these forms herself and fill it out herself at the time, so that when she has to perhaps remember or perhaps confirm whether or not the things that were in the report that the hospital made are accurate and reflect what actually happened, that she has a record also?
Well, I think that that's easy to do without any kind of legislative or regulatory stuff.
understand that.
You just, I mean, here's my sample, anyone can do something like that. But what I am more concerned about, what's more part of this legal process here, is that the information, the reason for transfer be accurate, because it has been my experience that in one instance I had a mother that had a footling, a surprise undiagnosed footling breach, and the only interaction between myself and the physician who was rushing off to the OR was to say that to ask me that we were purposely staying home with a footling breach, which of course was not at all true, but he didn't stay around to get my answer. And they were in the OR for a long time, and I wasn't there when they came out of the OR, and so I'm assuming had he filled one of these things out, it would read the, midwife planned home birth of a footling breach, which was not at all the case. And so I'm just concerned that either at the time this is filled out, probably not going to happen. I just, the bureaucracy aspect of it, but would this be publicly available? Could a midwife see what was said about her transfer and provide an amendment to it, a paper that corrected wrong data, wrong information? I don't have an answer for that.
I think the other thing that you brought up, Faith, that I think the board may want to correct on this form is protecting the confidentiality of both the healthcare provider assuming care, the licensed midwife, and the physician receiving care, to have all of those names on the second page so that they don't go to CMQCC, that they only come to the board. I think Faith made a good point that we're sending this information to an NGO, and perhaps they don't need to have actual names, that the hospital name is sufficient.
And Ms. Gibson, in response to your question whether it was public information, this form wouldn't be public information, but a midwife would be entitled to know either a summary or via a copy of the actual form what statements were made with regard to her care.
The copy would...
That's called an Information Practices Act request.
Okay, right. That would be appropriate. I would like to be sure that the essence of when we and why we transferred was actually accurately communicated, and like I said, have the ability to correct it or add a second page or whatever if that was the case. In terms of the concept of provide, is there a legal definition of provide that would require me to actually have physical copies for the hospital as opposed to having the chart available for them to copy, to look at and copy if they want?
I'll have to think about that some more.
Because I can tell you in the middle of an emergency transfer, I just don't carry my Xerox machine with me. Sorry. So that, that...
Seems like providing them and giving the hospital the ability to have them long enough to copy them should suffice, I would think, because...
I mean, that is what we've always done.
I'm trying to figure out what to do with electronic records of my transfer.
But we always had prenatal records and interpartum records with us, and many times the hospital wasn't particularly interested in reading them, but we did have them, and if they were interested, I would go with the person and watch them Xerox so that I always had access to, they didn't just send them off.
Yes. Are those copies of your wish list for the members of the...
They're for anyone who wishes them. There's 20 copies here.
I would like to see one, please.
They should go to staff. They should go to staff.
Give them to Natalie. She can pass them out. Thank you. Thank you.
Can I just ask a clarifying question of Carrie? So you're saying that it would be possible when a midwife makes a transfer to the hospital, and the hospital sends the medical board a reporting form, that then the medical board would then send a copy of the the form to the midwife to check for accuracy, and then she could get back to the medical board about, yes, this worked, yes, this is not accurate.
No, I don't.
That's not
what you
exactly
said.
right. The under Business and Professions Code 800C, there's a format where information from central files can be requested by licensees.
So we'd have to
Okay,
actually
so-
request it rather than you just
But
sending it.
the
So
board
it-
doesn't have to provide a copy of a record. A summary can be provided, and the licensee would be able to respond.
Okay, so then I'm just trying to outline the process. So I take someone in, I know they're going to make a report, the report's going to go to the medical board, and then I call the medical board and say, I know a report has been made, I would like to see what the details are so that I could correct any mistakes in it from my point of view.
Well, generally, you would send a request in writing
Yes.
to ask whether any information considered to be a complaint has been received.
No, I'm not talking about a complaint, and I don't think Faith is either.
a formal written request, I think, for the form is
And we can talk offline.
Is there
Okay,
any
thanks.
reason why, when these forms come into the medical board, we would not automatically be able to receive a copy of the report that the hospital has given about the transfers that we brought in?
Because statute doesn't say they have to give us one.
Wait, so wait. So
so-
by the same token, if you're going to transfer somebody to a hospital and the baby is going to be happening, whatever happens at a hospital to babies is going to happen, you're going to know that you had to transfer someone to the hospital, I assume, correct? Right. And therefore, you would maybe want to make sure that you personally would take the responsibility of contacting the medical board.
Right,
And
that's what we're saying.
That's all, but it's not like, this is not,
It's not incumbent on the medical board to provide us with a copy
No,
of the form.
I
It's incumbent on licensed midwives if they want a copy of the form to request it.
Right.
Is it clear now?
I would, and I will just add, in those areas where the midwives have strong positive relationships with the hospitals to which we transfer, we might be able to make requests of those hospitals that we be able to see the report before it is sent.
so might I suggest
That
that
might be-
might be your, that's
Yeah.
not what we should be
Yeah.
discussing here.
No, I'm just,
Okay, so, yeah.
I'm not
'cause-
discussing it, I'm just
No, but you're
making it
not-
as a suggestion.
Yeah,
But-
we need to move forward. So I think Ms. Davis is next, and then Dr. Gregg, and then.
Just a really
Renee.
quick comment. Rosanna Davis, licensed midwife, VP, California Association of Midwives. I've done a couple of transfers since the first of the year, and it's been extremely helpful in my communication during a transfer to inform the receiving care providers that I'm required to speak to the physician. It has improved communication immensely, or it has the potential of doing that.
Thank you.
Yeah, and I'll echo on that before my other comment, is just that that's highly important. I think the physician, even though it may be a CNM that's taking over care, the physician is the ultimate
Right.
one responsible. And where these transports have gone wrong is when the physician hasn't been notified that that's happened. So I think do that exact same thing. I think, I've had some midwives carry the copy of the law in, and so you're going to get the physician to talk to you, you're going to get them to copy the records and go forward. In our working group, it is a hospital to medical board and CMQCC form. We're trying to go very objective with the data, so you don't feel like you need to check it, right? So it's going to be APGARs, cord gases, things that are not narrative about the outcome. It's just really outcomes. Our hope with this is that you all would perhaps use that information in some form of peer review. That's the pie in the sky. Certainly hospitals peer review their own stuff, and that'll be done. And I would just think you might take advantage of this data and peer review in the future.
Yeah, I would, it's just occurring to me to make a small suggestion. The form that Karen created for the hospital transfers that's in the packet here, perhaps in reasons for transfers, as you're creating your ultimate form, that those ones that are the most common could be check boxes and a reason for transfer instead of having it be a narrative like it is on this form.
And Yeah, and I think the physician change to physician accepting responsibilities is important.
Great, thank you. Ms. Hannibal?
Renee Hannibal, certified nurse midwife. I thought, and so I'm up here just seeking clarification, I thought that the nature of that form was to improve communication and collaboration between providers. And if that form, if that midwife or that transferring midwife is not included in that process, if the hospital is the one filling out that form and submits it to the medical board and the licensed midwife is not allowed to communicate what happened during that transfer, then I don't feel that that is reflecting what the true nature of that form was meant to do.
Yeah, I think it's going to be an evolving process because the way that the law was written was that the hospital had to submit the form, so we have to go with that for right now. And I think as things evolve and these relationships are created between licensed midwives and physicians and hospitals, that midwives' input will be given. And yes, as I understand it, the legislative intent of this was to gather information about hospital transfers so that we could improve them. That's the whole purpose of this.
I think you're saying the same thing.
Yeah.
I think what we've heard from Dr. Gregg as well as from you and from what you're hearing from staff, that the object of this form was, it was legislative intent that it had to be done. The purpose of it is to elevate and to move the profession to a more professional situation, and this is one of the steps. Communication is definitely is part of that, so you're seeking clarification, you're absolutely right.
Yeah, and it's not meant at all to be punitive, and I would think that as things evolve over time and the hospital staff gets more used to seeing this form, reason for transfer, maybe they're going to start asking midwives, why did you bring this woman in? Especially when it's not obvious, you know?
So then will my medical records be accompanying this transfer of care form as well?
No, but you're not dictated to do it.
No.
You're a CNM.
Well, I have to anyway.
So the question is no.
But no, your records won't accompany the form. It's just these 2 pages.
Well, I'm asking because I'd like my medical records to be sent with the form. I mean, unless they're going to call me and ask me, the
hospital should have your copy.
Right, and it's not that I don't think that this will evolve over time and it'll be amazing, and I'm really glad that it's there, but I also know that communication between human beings and what is actually put onto a piece of paper can be quite gray. Yeah. So I would like my medical records.
I think we're just going to have to keep hearing back from everybody who's doing transfers as to how it's going and what needs to be improved on, and be a part of the process of creating the dream form that Dr. Gregg is talking about.
But this also might be part of what I was talking about. It's that after a certain amount of period of time, there's going to be a review of all of this and a revisiting of all of this. And that's the time to make sure that those comments are part of it, because the object of this whole process is to make things work better and smoother for everyone, regardless of what the title is that everyone's working together in a collaborative perspective. So keep in perspective that as these meetings go forward and these interested parties, make sure you're apprised of them and you participate.
Thank you.
All right, thank you. All right, Ms. Lowe, carry us forward.
Where are we?
I think we're on agenda item 8B.
Correct. Okay. So 8B is regarding the practice guidelines for California licensed midwives. Pursuant to AB 1308, the section in law, Business and Professions Code 2507F, which authorized the standard of care for California licensed midwives document, has been removed. In its place, the board has created guidelines for California licensed midwives. The new guidelines have been included on page 26 of your packets. Basically, the standard of care document has just been updated to come into compliance with the requirements of AB 1308. And at this time, we are asking that the MAC approve the guidelines to recommend to the full board in May. And then once the full board approves the guidelines, staff would then begin the regulatory process.
All right. Thank you. I read over these, and there are a bunch of places where I would make changes, but the one really important one that I think needs to be fixed is on page 28 or page 3 of this document, the first paragraph. Practice-specific guidelines and protocols are customarily implemented through standard or customized chart forms, informed consent, and informed refusal. And informed refusal has been struck there. That needs to be that needs to remain there. It's not related to a woman refusing to go to a physician when she's told she has to go. It's related to maybe she doesn't want to have an HIV test, and so she's going to give informed refusal for the HIV test. Or maybe she doesn't want her child to have vitamin K right after it's born. That's an informed refusal. So we need to leave that language there. It's not a reference at all to the woman being able to refuse and the midwife continue care, as we have in that subparagraph on I don't know, a couple pages forward. So I hope that I assumed that it was struck because there was an assumption that that's what it was referring to, and it's not. Mr. Jaslowski?
I read it also, and I obviously read it from a non-medical perspective, but more from just a legal document, so that for me, the terms like rationality bothered me. I mean, it becomes a value judgment versus what's rational to one person is not. I just would rather see some kinds of things like evidence-based or appropriately or effective. I don't know that. First page, I apologize, page 1, purpose, definitions, general provisions, number A. Rationally is I don't know. Then if you turn to the next page on page 20.
Excuse me, where do you see
like the word
rationally? Oh, I see it.
Midwife
I
practice
see it.
to be rationally evaluated. Rationally is like, I don't know, it's raining outside. I'm not real rational today. But that may be just me. It may be just my.
That is not something that can be very well defined.
Exactly. So I would just like some kind of standard for words that when we're using words in this. It continues on to number C on page 27. California licensed midwife provides care in private hospitals. A California licensed midwife may provide may provide care in appropriate locations. And then if you need to define them, you define them. But I'm not so sure that. I don't know, private offices, are we having them in the medical board, anteroom at lunchtime? I mean,
no, private midwife offices. I'm wondering if we want to pick this apart now, or if it's going to regulation. What's the process?
Okay, so first of all, these are the same standard of care document that has already been approved and has been in the works. So the only things that have been changed or edited to be stricken or added are based on what has been added or changed from AB 1308.
Right.
So the wording and the standards are not new.
Yeah, it's all old text. I think what you've done is you've underlined what you've added and struck what you took out, correct?
That is correct.
That which helped.
Okay. And I only brought up that one point because I think it's something that really needs to remain there.
I believe that this is so absolutely important to the practice of licensed midwifery in the state of California that it is not something that we should vote on today. I think we need to have input from the licensed midwife community at large in order to move ahead with this.
Well, it has to come forward as a regulation, does it not?
And then you have a meeting.
I understand that, and it does seem to me that it is jumping the gun to move this ahead as a regulation without the buy-in of the licensed midwife community.
So again, this is the same standard of care document with additions from AB 1308. So we can accept feedback and obtain the feedback from the council and the community, and then we can incorporate that information with the assistance of our legal counsel to then present to the full board.
Okay, wait, I have a question about process then. So it was my understanding that we were going to get a first look at this today, then there'd be an interested parties meeting surrounding it, then it would be presented as a regulation in October to the full board. Am I mishearing that?
We're not going to go through the regulatory process for this because it's practice guidelines, and it's like our prescribing guidelines for physicians. It's not a regulation. It's taking what the hard work that you've put into the standard of care and keeping it as something that's still viable for the community, and it'll be placed on the website as practice guidelines.
Okay, so then maybe I'm confused and we're talking about two different things. So I thought that this was being revised as the list of what had to have a referral for it that's dictated to be adopted as a regulation?
No,
That's not what this is.
no.
Okay.
This is what it is.
But
So we're just keeping this.
This
okay,
may
I'm getting it now.
change as a result of the work we do for those regulations.
Okay. I thought they were the one and the same thing. All right.
Okay, so let me try to
Okay.
provide some clarification.
Thank you.
So these guidelines without the strikeouts are what are currently in statute. The strikeouts and underlines are what are currently in regulation due to the fact that there was the 2507F. What has happened is with the elimination of 2507F, these are no longer, and the other changes due to AB 1308, the guidelines as they're written, without the strikeouts and underlines, are not in compliance with the law any longer.
Right.
Also, there is no regulatory authority for the old, what would have been the standards, because that section was taken out.
Got it.
In order to assist the midwifery community, what we wanted to do was put something out on our website that was now in compliance with the law. What will go through the regulatory process, which Natalie will be talking about at the end, is the 2507B1AI. I've seen that so many times but that will go through the regulatory process that then we will define what normal pregnancy and those things that are outside of that. That's where that will go through the regulatory process. That we have to have an interested parties meeting on.
So that list doesn't exist yet.
That does not exist yet. And so that will be a longer process. We were hoping that there would be agreement to where we would be able to bring that to this meeting between the outside interested parties. That has not happened. And so because that has not happened, we need something out there that provides guidance to the midwives right now. So that's why this was then revised. These will go out as guidelines. Because they are guidelines, they still have to be approved by our board. So you will be sending these to the board for approval. They will approve them, and they will then go on the website as the current guidelines, not as the standards that are in regulation.
So would it be safe to say at this point to licensed midwives that because there's no regulation that dictates what they have to transfer or consult for specifically, that if they stick with this for the moment, that they'll probably be fine?
Yes, that's why we put this
the foundation
in.
for right now.
This meaning
the amended document.
The revised
document.
Yes.
Correct. I'm speaking specifically to the lists of, you should consult for cardiac disease and pulmonary disease, those kinds of things. Because there's a lot of licensed midwives out there saying, okay, well, if we don't have the standard of care anymore, what's the list?
And that was our concern as well.
Yeah.
We didn't want to have nothing out there.
Okay.
And so in the interim time, until we define that B1A, that's this document that would be out there.
So then today, you really would like to hear our edits.
We would like to hear your edits today. We would also like your recommendation then to move it to our board meeting on May 1st and 2nd, so they can adopt these guidelines, so we can put it forward. So.
Okay.
I again feel like this is too significant for it to happen without input from the midwife community at large.
We don't have, they already gave input, Karen. They helped us craft this in 2005.
And again, I don't believe that the changes that are in here are any different than what the legislation is. Obviously we would like to hear from Cam today, and we'd like to hear from ACOG today on this, and we need the input so we can put it forward. But there's nothing that's different in here than that was in your prior ones, and that has not been changed from the legislative changes.
I appreciate that, and you are also saying that you want our edits. How can we give edits from the midwives if they have never seen this?
They've seen it.
Let me add this.
I've seen it in the revision.
Let me add this, though.
Yeah.
The only edits we're soliciting today is based on the underlines and deletes. That's it.
Oh,
That's a clarification.
Thank you, Diane.
Yeah.
That's very good.
So, all right. So then my comments, I'm going to go first because I'm the chair and I get to, would be on page 3 of this document, the first paragraph, to retain and informed refusal documents and treatment waivers. Save those because they're important pieces. And again, on page 4.
I don't have a problem with that. If you'll agree, we can put in a bracket something to the effect that does not include a waiver of referral to a physician in required circumstances.
I actually have a suggestion for how to handle that. So let me get to it just a second. On page 4, there's item 10 has the same language struck, and I would retain it.
Where are you again, Carrie?
On page 4 of the document 29 of our booklet, item 10, down at the very bottom.
Thank you.
Where it says, and informed refusal and treatment waivers, those should retain.
But I think you have to hear, but while you're making that recommendation, you've got to hear it with the other here, what your attorney said, because I think it's important. To your point, if you want to get your point.
Right, I have a way to solve her
Okay.
issue in another place. I don't have a problem with item 6. Let's see. I'm not sure why on page 8, that first line, healthy mother without serious pre-existing medical or mental conditions, why was that struck?
How are you going to
Because the criteria for initial selection assumes that you have a healthy mother without serious pre-existing medical or mental conditions. I think we could leave that there. Hang on just a second.
Criteria for
Let me get my answers. Do you know, did you just think it was superfluous maybe, or?
I think because it's defined under 2507.
How about if you make your recommendations and let your staff attorneys take a look at it and get back to you after you hear all the comments? Would that work? Because they're going to have more than this to look at.
Yeah, I'm just not sure whether it serves to
I
do it one at a
understand.
time or.
Right, and I think we're trying to work through the process to see if we can reach an agreement today, so.
Yeah, no, I meant in the next few minutes. I didn't mean tomorrow.
Yeah. I don't think we lose anything by leaving that, because it's a statement that, yeah, you're working with a healthy woman who doesn't have any abnormalities. It's just another way to say abnormalities.
All right, so here, and my suggestion is going to be is we go through this and then maybe take a short bio break and confer.
That's exactly where I was going.
All right. So,
Okay.
okay, so you just want me to keep going and then you'll come back to me? Is that what we're doing? As I read through this and I saw that you inserted current training and practice in obstetrics and gynecology, I see that in one place in AB 1308, and then in other places it just says physician and surgeon. And I'm wondering if anybody can clarify for me whether some of the time we're talking about any physician and surgeon, and some of the time we're talking about an obstetrician or a family practice doctor who has specific training in obstetrics and gynecology. Any?
Do you have a specific place where you're referencing?
I'm
Because
looking at page 9A. That's in the second line there of what you've added.
There.
What's our new law?
So 2507. There where.
I don't have a new, this is an old law. I don't have the new one.
If I could just give an example that would work with that is on the antepartum referral list is urinary tract infection. You know, somebody can go to their family physician who doesn't do births and get their antibiotics for a UTI without having to go to somebody who's trained in obstetrics and gynecology.
Right. So see, just let me interrupt for a second, because what I was doing was I was looking at the language in the law, and 2507, what do we have?
C1 plus physician.
Yeah, under in paragraph 2 here.
You're looking at B2, little b, and then 2.
Yeah, I
Starts
think
if a
so.
potential midwife.
Yeah, yeah, and then it
Client,
says,
okay.
for an examination by a physician and surgeon trained in obstetrics and gynecology. But then at other places, as you go down, like in C1, it says, if at any point during a pregnancy, childbirth, or postpartum care, a client's condition deviates from normal, the licensed midwife shall immediately refer or transfer the client to physician and surgeon. So it's not consistent. And I'm wondering if those who worked on this language could help me out a little bit. Ms. Davis?
Sarah Davis, California Association of Midwives. I believe that it's spelled out specifically the training in obstetrics and gynecology for the portion where that specific physician is assessing if the pregnancy can be determined to be normal so that the client can continue with a licensed midwife. So any physician who's going to be making that assessment that the midwife is going to be basing her accepting and continuing that client care on has to be a physician with that training. But if you're transferring them out and you happen to transfer them out of your care to an ER doc, I mean, there's no reason that shouldn't happen. So I think
So the determination of normal has to come from somebody who has training in obstetrics.
Yes.
But the transfer doesn't have to go to somebody who has training in obstetrics. Am I paraphrasing correctly? Is your understanding?
The first part of what you said, yes. The second part, I don't think that we worked on very clearly, and I don't think that it's necessarily important either
All right.
to this discussion, because as far as discussing like the client selection criteria and things that you need to refer for, those are all going to have to be with a if you're
It doesn't say that.
referring them for the approval to continue care, it's going to need to be someone with current practice in obstetrics and gynecology.
Well, actually, in C, little c, 1, it says it can go. They can be referred or transferred to a physician and surgeon when their condition deviates from normal. And then C2, it says, if the physician and surgeon determines that the client's condition or concern has been resolved, such that the risk factors presented by a woman's disease or condition are not likely to significantly affect the course of the pregnancy or childbirth, a licensed midwife may resume primary care. So in Ms. Marceline's example of a woman with urinary tract infection, and she sends the woman to her family practice doctor who has no training in obstetrics, and the urinary tract infection is resolved, and that physician who has no training in obstetrics says, no, you can go back to your midwife now. We've satisfied the law. Ms. Gregg?
Yes. In the law, it says trained in OB and GYN, and I think because it's just so many words, they didn't just keep repeating that after every time. You can check.
So you think it's implied?
It's implied.
Okay.
That was the intention. And I agree with you. I mean, if transfer needs to be happen to an ER physician, that's not at this point. But the deviation from normal is a physician trained in obstetrics and gynecology.
Okay, which could be a family practice physician
I don't know about that
with a
one.
fellowship in OB.
If they're authorized to do cesareans, they would be authorized to recognize deviance or not from normal.
Yeah, it's difficult because it doesn't say an obstetrician and gynecologist. It says trained in
Training.
obstetrics and gynecology. And technically, I hope all physicians come out of medical school trained in both of those things.
Right. We didn't go to the minute details of board
Right.
certified in OBGYN. That's true. Again, a lot of this has to be legislative intent. I think if I were referring somebody, I'd want to refer somebody who does that as their bread and butter every day. But I guess you could push it.
I'm playing devil's advocate here because I know that there are people who will.
Okay, I want to speak to that. So there are rural areas in California
identify
where the
yourself.
only people doing Constance Strock, California Association of Midwives, the only people doing OB are family practice doctors, like the area where I live. So there is no
True.
obstetrician at the local hospital.
It's rural areas, yeah.
Yeah.
There are also areas,
Yeah,
They were
No,
trained.
they practice OB and family
Practice and training, same thing? Training and practice in a situation sentence means same thing, I
Okay.
think.
Okay, I've beaten this horse enough, thank you. I would, and I'd like to hear what other people have to say on this. On page 10 of the document, 34 of the packet, antepartum referral, the following conditions occurring after acceptance for domiciliary care require physician consultation by the midwife or client referral to physician. I would really like to change domiciliary care to midwife care, because midwives are practicing in birth centers. It's my hope that we will begin to practice in hospitals as things move forward, and we're still going to be precluded from doing certain things, and we're still going to have to make these referrals even if we have hospital privileges. And so I think domiciliary is obsolete here.
Change it to what?
Change it to midwife care.
I hear what you're saying. Can we focus the comments so that we can get through
it
this
wasn't a
on
struck
to
thing,
the
was it?
underlines
Sorry.
and strikes?
Ms. Baravon?
Yes.
The further down in that paragraph, there is new text that
Right.
refers to the same thing. So maybe you could focus it on that, changing that to primary
you.
midwifery care instead of the labor
yeah.
and birth outside of a hospital.
Yeah, and I did have a note there. So we could change labor and birth outside of a hospital. You could replace that with licensed midwife attended care. Or return to the licensed midwife's care or something like that, rather than labor and birth outside of a hospital. So that it's clear that the midwife is going to manage the remainder of the care wherever that birth is taking place.
And if I may add,
yeah,
the exact same issue on the following page in, so page 12 and under A.
Yeah, it's the same thing. There, it's in a bunch of places. Everywhere it is, I would fix it somehow to make it clear that it's not. And here, actually, in A, referral does not preclude the possibility of a domiciliary labor and birth outside of a hospital. It could be, referral does not preclude the possibility of a midwife-attended labor and birth, period.
Right.
I'd like to go back to page 11. I think this is just a typo. Q at the top of the page, before the completion of the 37th week of gestation, 37 and 0/7 completed pregnancy, weeks of pregnancy. That's redundant. Yeah. It could be 37 and 0/7 completed weeks of pregnancy. And the same in R. And then on page 13, D at the bottom of the page is an ad. California licensed midwife provides records, including prenatal records, and consults with the receiving physician, and that should be about care up to the point of transfer to a hospital rather than about labor. Because it could be after labor has finished and the baby's already been born and the woman's hemorrhaging, and that's why she's there. And it could be prior to labor because she's 42 and 1/7 weeks and she hasn't had labor yet.
Carrie, does it make any difference that it's in the intrapartum referral section?
Thank you. I think that you intend this to be everywhere, not just in intrapartum, and I don't see it anywhere else. Am I correct? That's kind of a,
I think it comes from 2510, the language. It says, if a client is transferred to a hospital, the licensed midwife shall provide records, including prenatal records, and speak with the receiving physician and surgeon about labor up to the point of transfer.
no, it says labor.
What if it's postpartum?
Statute?
So,
Okay, well,
not entirely.
can't fix
appropriate,
statute, I
but
suppose, but,
That's where the language came from.
okay. We know what we have to do, I suppose. Okay, I don't have any more edits or corrections there. Do you want input from others before you tell us
You need to.
what we're going to do there?
Yeah, I think.
Yeah, I know. I'm just wondering if what the stepwise process is. All right, Ms. Marceline?
We're still just talking about things that are struck out or underlined.
Yeah.
I'm on page 9, the client's right to self-determination.
Oh, right, that's where I
B,
was.
struck out. And I just want to point out the internal inconsistencies here, because on page 1, it said we have to have a code of ethics and informed consent policies. On page 2, it says the licensed midwife's fundamental accountability is to the woman in her care. On page 6, we have a standard 4, that the licensed midwife shall respect the autonomy of the adult woman. I'm assuming that means anybody who could have a baby that we'd be taking care of. And all of those we would need to strike since we are also striking the client's right to self-determination.
I think actually, I forgot to do this part, which was my solution to the actual request that you had to make it clear that we couldn't continue this kind of care. I don't think that we want to strike that we respect the woman's autonomy. We want to make it clear that in respecting her autonomy, we also have to respect the confines of our license. And I think we could do that by modifying paragraph 5B on page 9 to make it clear that the client retains the right of informed refusal. She doesn't have to go to the physician or the hospital because we tell her to. And we can modify this paragraph to say that if she is refusing, she has that right to refuse, but we need to inform her that our law does not permit us to continue caring for her at that point. So that we retain the essence of respecting her rights. And I know this isn't going to make people real happy, but it's the best I can do given the law. And at the same time, we acknowledge that we can no longer continue to provide care for her in that setting.
I know this is a big sticking point for midwives throughout the state and for mothers throughout the state. And I still wonder about the whole thing of patient abandonment. If we've got a situation that comes up late in a pregnancy where there is not time to enlist another care provider to take on that woman's care, how do we have the right to tell her we will not attend her and help her? Because these things are going to come up at the end of a pregnancy. We can't predict them.
I hear you, Karen. I'm wondering
I'm just trying to reconcile it. I don't know how to.
Maybe Dr. Gregg, you could give us some input here. What happens in the hospital if you're giving somebody advice and they won't take it and you don't want to continue to care for them given that they've refused the care that you're offering? What are your rules around patient abandonment?
Yeah, we have, our license comes, it's a privilege, and we follow it, and they hold us to it. So if someone asked us to do a hemorrhoidectomy, which is very much within our ability because it's down there, we don't do it. yeah, the only rare case would be if someone's, the sort of the Good Samaritan rule there, that you're at a crash site and you know that she needs a trach, and that's not part of my privileges. I can do that. I could do that in the hospital setting too. So we discussed this when the law was being developed. We said that certainly if it was life and death situation, you continue to treat. But at the end of a pregnancy, or when someone's asking us to do something as a physician, if you have half an hour, we can hopefully get that patient to the right care, and usually it doesn't necessitate that 30 minutes to get them somewhere else.
What if there is no one else who will provide the care the woman's asking for? How do you... It's a sticky wicket, in my opinion.
They trust you. I think you guys, they trust you. And if you say, you can guide them to help them make a good decision, I think in most cases. I know that there's those that you can't, but they trust you.
I agree. Ms. McLean, thank you.
Hi, this is Teresa Mclean from CFAM. To that point, I think that the autonomy that women have is that they make decisions based on their whole life experience and everything that goes into it. And while we guide them, there are many women who've chosen midwifery care because of their love of autonomy, because of their agency, and they will not actually go to a physician. And I think that it does need to be addressed clearly for the midwives as well as for the families. And this week I have heard from several sets of families about this issue in particular, and it's something that CFAM will be taking on. And I know that this isn't the appropriate place to address all of these concerns, but I do think that this specifically needs to be addressed.
And I understand
in terms of abandonment.
There's a lot of broad concerns. We do have to stay focused on language.
I understand.
Right. I think Ms. McLean and all of us are recognizing that the board's hands are tied in terms of giving us license to continue to care for somebody who's essentially is risked out of our care by statute. We can't do that. I think that midwives are wondering, well, what are the rules around abandonment, and how do we create language that makes it clear? I think in this paragraph we could recognize the woman's right to self-determination, and we could put in something that says that, a licensed midwife, the woman's been informed that a licensed midwife can no longer continue caring for her, and appropriate referrals to other care providers have been given, or something along some kind of language similar to that, so that we're not saying that the woman doesn't have the right to say no. We're just saying that
you have the right to say no.
That we have the right to say no, and we must say no.
We have the
given our license.
obligation to say no.
Exactly.
It isn't something we necessarily all of us want in the state, but it is our obligation now
to say no
legally.
Yeah.
And I think that for parents as well, Carrie, that it's important that this is spelled out, helping to maintain their autonomy as much as we can, acknowledging they're actually not maintaining it, acknowledging it because it already exists. Thank you.
And this really goes back to what I said in my address earlier, that it's now incumbent on all of us to work really, really hard to find those options for women in their community that we cannot provide, but that they're going to want. Normalized physiological care past 42 weeks, vaginal birth for breech, vaginal birth for twins, those kinds of things. We have to help search out those things. But
Carrie,
Can we bring it back?
Yeah.
The reason this was struck is for a very good reason. It's basically saying that in spite of the fact you've given your good recommendation, you've advised the patient what to do, that you may then continue. And the issue is you may not continue.
Right. So
that's why we understand why this was struck.
No, I understand it.
Okay.
What I'm saying is to retain part of it and make it clear. And that would, I think, solve Ms. Webb's issue in the other places where I was saying we needed to leave the consent issues, the consent and treatment waivers in. Informed consent, informed refusal documents, and treatment waivers. That if we could modify this paragraph in such a way that it globally fixed that,
So the current paragraph does state that the client should be informed that unresolved significant risk factors would limit the scope of midwife's care to provide concurrent care with a physician, regardless of whether the woman has consented to care or refused care by a physician, which says that they don't have to see a physician, but you're unable to perform any further services if you don't get that release from the physician.
Oh, I see what you're saying, to leave it because
As
it's in
it
paragraph
is.
A. Yeah.
Which is why that is being added. So
Doesn't paragraph A say what you're saying?
That's what I'm just rereading it. Yeah, I don't know that we're gonna.
I think that's why you need to let your legal staff go through and hear the objections, and then, or the additions, and then come back after 20 minutes or 10 minutes or 5 minutes.
Faith Gibson, one last point having to do with these informed refusal on treatment waivers. For example, Christian Scientist women have treatment waivers and informed consents relative to doing normal routine blood work. There are other issues like that that have nothing to do with whether or not they're post 42 weeks or the baby's breech or the like.
It's a normal pregnancy.
So there are all kinds of things. We still have to do all those other things. We hope to respect their choices in those regards.
Right. Thank you. Did you have something more, Tosi? I know I kind of interrupted you midstream there.
No, I was just thinking if you take out the second sentence and leave the first one in, and then add something that says the licensed midwife must inform.
It could be
the client that she can no longer care for.
that is currently included. It's the last sentence in that paragraph.
That's in the upper paragraph, but in paragraph B, if you retain that first sentence and then say,
the second one.
And the licensed midwife will then provide appropriate referrals and cease care or something along those lines.
And
Ms. Davis?
So with regards to everything that's come up to now and this discussion, the California Association of Midwives is in support of this document as guidelines, as with the edits from staff and Ms. Sparavan today. And I think on this particular page, on 5 with these risk factors, there's some philosophical and emotional attachment to paragraph B, and I don't see that it makes any substantive difference. The issue of client autonomy is important to California Association of Midwives and to all the other stakeholders here, but I think that this conversation is derailing into our attachment to this paragraph, and what staff has put into the first paragraph does seem to actually cover it all.
Okay. And would the representative from CFAM concur?
Well, and let me say that, given that what Ms. Lowe said about where this is going and that more regulations are coming, and that this is actually only providing sort of a stopgap of guidelines, and as guidelines, this isn't even regulation. This is just what we're going to sort of be using to determine in the interim what we have to refer for. I don't see that beating this horse any further is helpful.
So I wouldn't hold up the cart.
What's your name?
Teresa Mclean, CFAM. I don't think CFAM would hold up the process. But what I would say is that for families that I hear from a lot, this is a very important acknowledgement of women's autonomy. And I think that a simple acknowledgement of that is important. But I don't think that because we have much farther to go in this process, I wouldn't hold anything up today over that.
So let me ask you a question. Would leaving the title in And leaving it exactly as it is?
I didn't
The title
bring my-
being responsibility of the licensed midwife and the client's right to self-determination as a heading, and then leaving the first paragraph there, would that satisfy what we're discussing here?
So you're talking about making a responsibility of the licensed
I'm
midwife
saying-
and client's rights to self-determination
As a title.
as the title?
And then having your paragraph A
paragraph,
as,
the way that it's
paragraph A as stated, leave it as is.
Okay.
Which basically just says that the
Just what you were
clients
saying.
don't have any rights to self-determination
Yeah,
if you put them together.
It's basically
Don't
true.
get it.
We have to understand that if autonomy is not supported with adequate care, it is false autonomy.
Right. So the midwife has a responsibility.
Yes.
And the patient has a responsibility.
Yes.
Patient's responsibility can be to decide what they want. But regardless of what they want, the midwife has the not only responsibility, but the law demands that they have to follow what they are prescribed to be allowed to do. And if they've recommended someone to go to a different practitioner, that's within their right and their responsibility, their license. To lose the license is much worse.
Oh, no,
So
I don't disagree with
But
you.
if the choice is, but if that's the choice, should a practitioner do what they are supposed to do according to the spirit and the letter of the law? The answer is yes, regardless of who likes what.
But this is what Carrie's saying, is we acknowledge a woman's autonomy, we make proper referrals,
Right.
she makes decisions based on those referrals, and we cease care under the law.
But isn't that what I am? But so,
But I don't think it's clearly defined that. And again, I don't want to totally sidetrack us because I know there's a lot to do today. But I would,
My angst on continuing to whip this horse is that I suspect that when we get to regulations to satisfy AB 1308, it's not going to include narrative like this. It's going to be a list.
exactly right.
And we're not going to have any of this, and this is our shot at making this as
from the
User-friendly.
perspective
Nice as we
of the families that I've heard from this week alone, this is a very important issue. And a lot can be gained by acknowledging very specifically their autonomy.
And I point out that it is the purview and the purpose of the Medical Board of California to protect consumers. We're not here for the licensees so much as we are here for the consumers. And we're hearing from a consumer group that it would be really helpful for consumers to have this acknowledgement. So,
Something.
yeah, please.
As a consumer, I agree that it's really important to acknowledge autonomy. But I also agree with Carrie that I worry that if we don't have this conversation now, we won't be having it later.
Yeah. Ms. Webb, is there a problem with taking that recommendation, leaving sentence number 1 and making sentence number 2 something to the effect of, if the client has signed this informed refusal, the licensed midwife will then cease care and provide appropriate referrals for the client to continue care with another care provider or with a
Which is
physician or whatever.
essentially in practice what we have to do.
Right.
I mean, it's just defining what we have to do with an acknowledgement that women have the opportunity to make those choices for themselves.
And it is, I'll acknowledge
Unfortunately,
that-
I'm a midwife and a consumer, so I have.
And it is a bit of a restatement of the first paragraph, but I think we're hearing that it's really important to leave that sentence, in recognition of the client's right to refuse that recommendation.
We could also, the language in the law to me is pretty cut and dry, oh my, but we could copy the exact language from the law into the guidelines, which would then read, a licensed midwife may assist a woman in pregnancy and childbirth only if an examination by a physician and surgeon trained in obstetrics and gynecology is obtained, and the physician and surgeon who examine the woman determines that the risk factors presented by her disease or condition are not likely to significantly significantly affect the course of pregnancy and childbirth.
I think using that whole paragraph muddies it a little bit because it makes it seem like every woman is going to have an examination by a physician.
It also suggests that being pregnant is a disease. I think you guys need to, I think that, that the beating of the horse is only gonna, is create, I mean, I can go with what you're suggesting, first sentence and change it, tweak the second. Just be careful where you're going, because we've just heard for how many years that being pregnant is a disease. And if we want to go back there.
No, we don't.
Okay.
Is that?
We have a law in California that says that pregnancy is not a disease.
So,
But how many Republican men have you heard?
Okay, so
Yeah, I know.
let's
all right.
let's
In the
move
interest
on.
of time, let's move this forward. And you're going to tell us what you think about this when you've heard all the
We're
comments.
gonna,
Is that right?
Yeah, we're
okay.
gonna take a break and
All right.
talk and see
Are
what
there
we can
more
come up
comments from anybody at the council on this language, or could we break? Could we take a? Okay.
Just to make it consistent, I agree with you on page 8, why healthy mother without serious pre-existing medical or mental conditions was removed. That seems against the spirit of the law.
Okay.
And if we can just, as we did on the following page on the other lists, we sort of do an include but not limited to.
That's good.
Include but are not limited to.
I'm sorry, which page are you
So
on?
specifically on page 8, adding to that list,
Okay.
include but not limited to, because it's impossible to list
following.
everything. And your other lists start with that language also. Include but are not limited to.
Include this.
Here. And that's how it was previously. We didn't remove that from the language.
Right, but it should have always been there. So.
My concern is that you're going to have people. That's what you don't want.
Yeah, just so that it's consistent in the as it is in the referral section. Right. There.
That's why be careful.
Any other comments, or can we take a really brief 10-minute break? Like, I'm really going to start back.
Depends on your staff.
We do that? Yeah,
They need to
we
get
all
to
need
it
to do
first.
that. Yeah? Are you ready for a break?
Do we have all the comments related to these proposed guidelines?
I think we do. I'm not seeing anybody else asking for comments. So I have 312. So 325. We'll come back. Yeah? All right.
Stories, these are real people.
All right. So I'm going to pass to Ms. Webb to tell us what she's come up with here.
Okay, so on page 3 of the guidelines, page 28 of your packet, we'll leave the and informed refusal documents in place, but still strike and treatment waivers, since it should be, your concerns should be addressed by leaving and informed refusal documents in place.
Okay.
Page 4, number 10 down there, same thing. We'll leave informed refusal documents in place and strike treatment waivers. Page 8, we're going to keep the healthy mother without serious pre-existing medical or mental conditions. And we're going to add, after following, a comma, including but not limited to, colon. Page 9. We're going to add a new paragraph that says, it is recognized that the client has the right to refuse the recommended referral, comma, however, pursuant to the law, the licensed midwife cannot continue care.
The licensed midwife will document refusal of the referral in the client's record.
Works for me.
On page 10, we're going to accept your request to strike domiciliary care and have care by a licensed midwife. And then down below, we'll strike labor and birth outside of a hospital, and it'll read, a referral for immediate medical care does not preclude the possibility of care by a licensed midwife if a physician who has current training in, etc. On page 11, we're going to, under Q, strike pregnancy.
The first pregnancy?
Yep.
Okay.
And on R, strike the first weeks of. On page 12, we're going to say referral does not preclude the possibility of return to care by a licensed midwife. And we'll strike labor and birth outside of the hospital. On page 13, we talked about D. Since that's from the law, we're going to leave it like that.
Got it.
We can work that out at another time. It looks like that's it.
Okay. Ms. Rock?
It's just a small grammatical thing, but in, let's see, where was it? 12A.
For the last
Oh, I'm
edit
not
that
seeing
you
it.
made,
Yeah.
For return to care by a licensed midwife, maybe return to care with or return to care of a licensed midwife?
Yeah, I think
Just
it
the
should
by.
be with, because it
With,
clarifies
okay.
it.
I'm fine with that.
Okay. Anyone else have any comments, either from the council or from the public? All right. Motion to refer this to the medical board?
Yeah.
Motion now?
Yes, please.
So I make a motion with the changes as we've heard for this to be concluded.
And presented to
And
the,
presented to the board
For acceptance.
for acceptance, yeah. Will you put it in language of the motion?
Do I have a second?
Yes, you do from Karen.
And
Correct? Is that what I heard? I didn't know. I apologize.
It was Monique, but that's
Okay.
I apologize. I heard it came from that direction.
Second from
I
Ms. Webster.
apologize. Monique, I knew it came from that direction.
All right. All in favor? Aye. Any opposed? Abstentions? Okay, so it carries, and we are going to send this document as revised to the full board for approval. Yay.
Okay. Agenda item 8C, pathway for certified nurse midwives to become licensed midwives. At past MAC meetings, the idea of approving certified nurse midwifery education programs, as well as the idea of allowing CNM licensure as a viable method of applying for an LM license, has been discussed. The board has reviewed this idea and is pursuing obtaining additional information from outside sources to determine the viability of these options. And at this time, we're more inclined to pursue the option of a CNM licensure as a pathway versus approving CNM education programs, as education would require approval process for the actual programs, which would quite lengthy and could be multiple schools. I have currently requested information from the American College of Nurse Midwives and will also be in contact with the Board of Registered Nursing and the California Nurse Midwives Association to gather more information on this idea. Once we do obtain the information, staff will review, and we'll be providing an update hopefully at the next MAC meeting with our findings and what our actual options are if the licensure components are equivalent to California's licensure standards. So it'd be looking at accepting licensure as a CNM in California as well as across the United States, and those are the different items that we have to look into further.
So basically, if they had a CNM license in any state, then they could just ask for reciprocity for their licensed midwife?
Those are
that's
an option that we're looking into, but in order to do that, we're trying to obtain, and that's why I've contacted
all these people,
the National Association to find out what their standards look like for across the U.S. versus just specific to California.
Probably pretty consistent nationwide, but great. So by August, you'll be able to tell us whether or not we can go that direction, do you think?
Hopeful, at least provide you some feedback on the pros and cons of that idea. So.
Okay, perfect. Thank you.
Okay.
Is there any questions about that? Or, oh, yes, we have.
It was an excited oh yes.
Yes, it was. I'd forgotten, actually.
Hi, my name is Kim Doe. I am the Health Policy Chair for the California Nurse Midwives Association. And I did want to make some comment on this on this particular issue, especially to follow up on some concerns that our members had and have also brought up to the BRN. So first, I wanted to put it out there that it is absolutely our primary policy agenda at CNMA to remove supervision for certified nurse midwives as well, and that we recognize that the number of CNMs that have been going to the medical board seeking a pathway to LM licensure is because now there is no supervision in place for LMs and there is supervision in place for CNMs. You know, one thing that I'm sure that this that the MAC is well aware of is that, and I think, Carrie, you've already pointed out, in our thoughts, in our language, and I think in the common perception of the differences and commonalities between licensed midwives and certified nurse midwives, it's quite obvious that we think of licensed midwives as the home birth midwives, and we think of CNMs as the hospital midwives. And as you pointed out, Carrie, there's I'm sorry, Ms. Sparavon, I'm sorry. There's licensed midwives have the ability to practice out of hospital as well as in hospital. And similarly, certified nurse midwives have the ability to practice in hospital as well as out of hospital. The out of hospital certified nurse midwives are in the same situation that the out of hospital licensed midwives found themselves in, which is that they're unable to find supervising providers, supervising physicians. So they are seeking this pathway. It's a step that I think the intention of it is to protect one's ability to continue practicing midwifery in the many ways that looks. But it's important to keep in mind that in thinking about this pathway, the possible legal limbos that might come up for certified nurse midwives that are practicing in out-of-hospital settings and continuing to practice in hospital settings. So we've brought to the Board of Registered Nursing the question, if a CNM certified by the Board of Registered Nursing decides to obtain her LM, his or her LM, what would that mean in terms of their license to practice nursing and their certificate to practice midwifery? And just a small clarification that in the state of California, we don't have a midwifery license as a CNM. We only have our RN license and a certificate to practice nurse midwifery. So this is a concern because a number of our members have a home birth practice, but may also be providing CNM services within the hospital, which includes furnishing medications and so forth. So I would hate for any one of our members to be in this space of having her LM, and which she intends to use for her home birth practice, but then also maintaining her CNM to continue her in-hospital practice or clinic privileges, and be held accountable by the BRN when she's practicing home birth without a physician supervisor.
Which is going to happen, am I right?
So, you know, I'm always one to think that if it's possible, it may end up happening. And certainly we know that unlike the medical board, the BRN is actively bringing investigations against CNMs in home birth settings, looking into their meeting of the supervision standard. So I just wanted to pose that as a potentially very complicated issue, and I don't have a solution for that. But that as you're thinking about that pathway, that I think that we have to also be really clear, both from the BRN and the MBC, what the expectations are on that individual who carries two licensures.
Yeah, Mr.
Can I don't know that it should be directed to you, but I'll direct it to my staff. But the question is on clarification of a certified nurse midwife and a licensed midwife. The supervision for this certified nurse midwife is under the Board of Registered Nurses, and we are over the licensed midwives. And we have worked for years now to elevate this profession, ensuring that there is transparency as well as accountability, as well as remediation. I don't personally have a clue as to what the BRN does to make sure that this is going on, other than I always thought that certified nurse midwives practice in a hospital setting under physician supervision. So if that's not exactly true, and what I'm hearing is more of a equality of professions, it may be better for us to get our stuff finished first, but then on the other hand, I don't know if there is a level of the professions being equal. So
I think the hang-up is going to be exactly the case that Ms. Doe was pointing out, is that if an individual holds both licenses and is non-compliant with one of them, and that the board that issues that license decides to go after them for that, there's nothing that having her LM is going to do to prevent that, as far as I can tell. That the only thing that would be helpful is if there was a
What I want to understand more is from the perspective of that person practicing out of a hospital situation as a midwife, under whose auspices is that allowed to happen?
Well, if she holds both licenses, it's under both auspices.
Right, but currently, today, that license is held.
CNM, it's under the BRN.
And
if
the
she's an LM,
BRN,
it's under the MBC.
so the BRN allows for their practitioners to practice out-of-hospital births.
Only if they have a supervising physician. They're in the same catch-22 that we were in before we removed physician supervision.
And they're allowed to do it outside of the hospital?
If they have a physician supervisor.
Absolutely. And I apologize, I got this letter in late to Ms. Baravan, but I did provide a letter, and on the third page of that letter, provided the B&P code for licensed midwives prior to 2014, and the B&P code for nurse midwives currently, and it's essentially a cut and copy. It was
designed that way.
It is a cut and copy.
That's what we did.
It's just designed that way.
We're ahead of the game now, right?
Can I ask a question to you? If your law changes to where supervision is no longer required, then if I'm understanding correctly, there'd be no benefit then of obtaining an LM. That CNM license would be basically equivalent, and then this would be possibly a moot point?
Yes.
So, I think the assumption, or the big question is whether or not we're going to be successful in removing supervision.
You don't have a bill this year, do you?
We don't have a bill this year, and we have a lot of conversations still pending, and there's certainly pushback from medical associations. Well, we would assume that there's pushback from medical associations given the response to the nurse practitioner attempt last year as well. So
yeah, autonomous, yeah.
So my feeling is on this is that it's not. It's definitely not a secret that this is a policy priority, but it's also not a secret that it's politically very challenging. And that said, I am interested in making sure that certified nurse midwives who want to provide out-of-hospital care to their clients can do that legally. And right now, the only way they see that possible is to become a licensed midwife. And so I'm not trying to put a kibosh on the process. I simply want to point out that this is very complicated.
Can you stay after, please?
Yes, ma'am.
I think that where it's complicated, though, is for your members, for CNMs who don't give up their CNM license or their RN license to become LMs. It's not complicated for the board, particularly in deciding to allow a CNM to become an LM simply by virtue of the fact that she is a CNM. That's not a complicated part for us, and it sounds to me like it's going to be at least 2 years before you get rid of supervision. I don't know. It seems to me.
Ms. Sparvan, if I might add to that, though, on the other side of this, you have CNMs. The CNM may practice in the hospital for women that are insulin-dependent diabetics. They'll be furnishing. So I think that there is a potential for the board to, because again, that individual is responsible if she has her licensed midwife, her LM in addition to the CNM. She's responsible to the MBC when she's in her in-hospital practice as well.
Well, we already have that situation. I know of at least one LM who is also a CNM already. And I also know of several LMs who are also physician's assistants, which would be a similar situation. 2 of those LMs also have hospital privileges as PA midwives. So I think while it's rare now, I don't think it's unique. And my vote would be to provide as many safe options for women in California as we can provide. And if one of the ways to do that is to provide an avenue, a relatively streamlined avenue for CNMs to become LMs, then we should try to do that.
I would say
I hear your concerns. I definitely, and they were already swimming around in my head before you raised them. So
yeah, I would say that this conversation would be more fruitfully directed at the BRN than at us, because we're inclusive. We like you guys. We want you to join us. We've invited people to join us in the past. The more, the merrier. But we have, and it's something that we have had in our plan ever since we got our licensure in '93, was to someday get rid of supervision for everybody, and that whoever got it first would bring the other people along. We've had 2 big legislative pushes in probably the 90s now, I don't remember, a long time ago, where LMs and CNMs joined the legislative process, and then one of us dropped out hoping that the other one would get it, and then we reversed it the next time. And I don't know, there's a lot of history there you should look into, and a lot of really good arguments.
So we have reached out to the BRN, and we've had the opportunity to talk to the executive director, Louise Bailey, and she and the legal counsel at DCA as well. And what she told us is that she is in conversation with the medical board, and that they'll be looped in and having conversations. So yes, I agree that the BRN is also needing to be involved.
Great, thank you. Are there any other comments on this agenda item? All right. Bring us forward, Natalie, please.
Okay. 8D, possible revisions to the licensed midwife annual report, as we previously discussed in the meeting. Basically, at this time, we are going to be creating an interested parties meeting to go over the different data elements. And earlier in the meeting, we were discussing, Kim and I, that possibly a task force could be created with Carrie and Karen, and you could work with board staff to kind of figure out the data elements and the formatting of the report that you would like, and then we could take that to an interested parties meeting in July, possibly dates fluctuating, but based on that information, our internal IT staff could probably come up with a system that would work for all of us. and then provide that to OSHPD to release to the licensed midwives for submitting the report. So if you're in agreement, we could and request the task force be created for that.
Yes, please.
Okay.
So Karen and I are the task force? Is that what we said?
I'll leave that to you to make that determination, but that would be the board's recommendation or the
Would that
staff's.
then, that would then require noticing because there would be 2 of us from the council?
It would.
That's okay.
All right.
That's okay. Okay.
You'll do it. I take it under advisement.
All right, I'm going to think about it until the end of the meeting, because I'm not sure I'm the most appropriate person, actually, to do that.
Can there be others from off the council who would be
No.
a part of that meeting?
Only need 2.
2 from the council
Only
for interested
2.
parties.
Only 2 if we're going to do it as an unnoticed meeting, correct?
Yeah, it would be
2
a work
period.
group that you could work with staff on to then take to the interested parties meeting, which would be noticed.
But there could, if there were 2 people from the council, could there then be outside people also
No.
involved in
No,
that
that's
meeting?
what I'm saying, no.
No.
It's only 2
okay.
people.
Okay.
All right.
Okay.
Okay.
So, and that's basically the update. I'm not going to get into any more details since it was somewhat discussed earlier, but we can go from there. All right, then I'm going to move on then to 8E, which is a challenge mechanism changes. AB 1308 added to BNP Code 2513A. The beginning January 1st, 2015, new licensees shall not substitute clinical experience for formal didactic education. Concern has been raised as to whether this would eliminate the challenge mechanism altogether, and if so, what the options would be for midwives who did not meet the formal education requirements. There's also been confusion on what elements could still be challenged. Staff and legal counsel have reviewed the issue, and the board's stance on the law is that education can be challenged, but clinical experience would have to be completed at an approved education program.
What?
The determination of whether or not the education satisfies the requirement in law would then be left to the approved challenge mechanism providers to determine if it meets California requirements.
But, whoa, I'm really confused now.
Yeah. Seems backwards.
Yeah. The intent of this law was that you wouldn't have only clinical experience and no formal didactic training, not that you couldn't challenge your clinical experience. And there's no point in having a challenge mechanism if all of the clinical experience has to be gained at a formal school. That doesn't make any sense, and that wasn't the intent of the law. So I'm not really sure how we got there.
Yeah.
The intent of the law was to say that even if you're challenging, you must have some formal didactic training. But that didactic training doesn't necessarily have to have been gained at a board-approved school.
We've been working through this, and it's still a work in progress. And I think that you can't use your clinical experience to challenge didactic requirements. Correct. But I think you are, if you've been a licensed midwife somewhere else, in England, for example, and you come in, there should be a way to challenge your clinical experience to clinical experience, your didactic to didactic, and this is going to be, we're going to be working with the schools to make sure that it's meeting our requirements.
What I just heard Ms. Lowe say was that, and maybe I misheard it, but I think other people heard it the same as I did, that clinical experience would have to be formally gained rather than be challenged. Is that what you intended to say? Could you read?
Institutionally gained.
Read what you read.
The clinical could be challenged, but the education could not be.
Okay, I heard just the opposite.
You said the opposite.
I heard the opposite.
Using clinical.
Could you read it again?
If I read it again, it's going to say the same thing, so it's not written correctly.
All right, so what you meant to say was that
Clinical competencies, yeah.
Help me out, Carrie, please.
Did what I said make sense?
Yeah, it said perfect. It made perfect sense.
Right. That's right.
What that meant, let me just give you an interpretation, because my understanding of what that means is that the legislature wants all midwives who will be licensed after January 1st of 2015 to have some formal didactic education. It is not specified what that will look like. It does not say that they must have gone to a board-approved school. It just says they must have some, in other words, they have to have had some coursework rather than learning everything on the job in an apprenticeship model, which is how we've been doing the challenge mechanism. That was one of the ways for women to do that.
We might call it institutional.
Right.
That might help with the just conceptualizing it.
Yeah, but there's many ways for that formal didactic education to happen that isn't necessarily going to a board-approved school. And what I want to be sure we do in this interpretation and as we move forward is that we leave the way open for midwives who are trained in a state that doesn't license anybody yet, who have gone to a midwifery education program that has formal didactic education attached to it, but hasn't been approved by California yet. They would then have done that work, but now they have to do the additional work of going through a challenge mechanism and proving that the didactic education that they got was sufficient for California's licensing requirements.
Isn't that what this
Does
says,
that make
though?
sense? That is what this says, but that's not what she said.
Yeah, but so we want to make sure that what you're saying is what we're reading on page 41.
Page 41?
It's in the interpretation, I think.
Isn't that agenda item 88?
Right. It's that very last sentence in the first paragraph. And
That you can't substitute clinical experience for formal didactic education?
And what you are saying is what the board stance on that. That is correct.
Right.
okay, so we're in agreement then. So the challenge mechanism remains intact. It just has to now have an additional requirement that anybody going through it will have to prove that they've had some formal didactic education somewhere, somehow.
That's correct. And the board will be in contact with those challenge mechanisms to ensure that they can meet those requirements and demonstrate how they will be evaluating that.
Got it. Okay, good. We're all in agreement then. Thank you.
The exam, we're going to also have to approve, the proficiency in exam, okay. Okay.
Okay.
Okay. So I'm going to move on then now.
Yes, please.
All right, 8F, findings from survey regarding impact of implementation of AB 1308 pertaining to the practice of midwifery, drugs, and devices. At the December MAC meeting, it was requested that feedback be obtained from the midwifery community regarding their experience in obtaining lab accounts, supplies, and devices following the implementation of AB 1308. A survey was generated by board staff, and with the assistance of CAM, it was sent out by email to their members. And the results of the survey have been provided in your packets beginning on page 42. Survey results provided were as of Monday, March 24th, and reflect that 48 individuals participated in the survey. I'll briefly go over the findings with you. The first question asked was, since the law has changed, has a lab refused to provide you with an account? Out of the 48 responses, only one person responded yes, that they had been refused an account, and they did not provide any open comment field text to indicate why that may have happened. So that was one of the main things that they were concerned with at the last meeting, and that doesn't seem to be an issue. So the second question asked was, since the law has changed, if you've been provided a lab account, have you been able to order testing and receive reports? The negative responses on this were a little higher, with 10% indicating that they had not been able to order testing and receive reports, but still the numbers are very low.
And we don't know why, right?
Well,
there was no free text or anything.
Yeah, there was no comments on why that had happened, but I'll kind of get to the open comments here in the end.
So slow down just a second. Okay, so when you ask the question, have you been denied? And the answer comes in. And then you say to the person that has been denied, you've given them the copy of the law, and are you still being denied? And the answer is yes.
Correct.
So then my question would be, is there a way of figuring out who those people are specifically and for us to be able to ask staff to direct some kind of a printed notice. It's been noted by our department that there might be some misinterpretation of the law, and we just want you to understand that the law is in fact this and this, and we would hope that in the future that you would not be denying access. I mean, is there a way for us to, we've asked the questions, they've given us the answers, and yes, and so? How are we fixing the problem?
Right. So on the survey results, open comments, I'll just fast forward to that, was most of the responses that were received as just comments on the overall survey, which was the last question, was that the majority of the midwives that answered the survey were not actually having any difficulties with any of these things, and they'd actually not had issues with this prior to the implementation of the law, that they were thankful that it was now in law, but it really didn't seem like an issue to them. So the only thing that I think, based on the small amount of results that we had that may at this time require a little further outreach, was that on question 5, which was, since the law has changed, have you referred clients who were denied ultrasound services or genetic counseling? And based on that, there were 8 responses saying that yes, they had been denied.
17%.
And so that was something where it would have been beneficial to find out from them, what were you requesting, a normal ultrasound, or was it something out of the norm that was denied? What I'm recommending is that, because 48 people responded to this survey, but there was the majority of the responses were not applicable, which was also documented in the open comments, that they had not actually needed to order the testing or request supplies, or they'd already gotten their supply order and they'd do it next time and see what happened, is that board staff would then send out the survey, a follow-up survey, prior to the December MAC meeting, so that we would actually get almost a year of the law being implemented to see what the actual issues are with these changes. So,
is it possible that we could add these questions in when the LMAR is done for next year, so that we, I'm not as a part of that, but kind of buddied up to it, or perhaps when the notice goes out to the midwives saying it's time for the LMAR to go in, we also need you to answer this other survey?
I mean, we can definitely talk about outreach and how we would get the survey out to the licensed midwives in California, but for a survey, 48 responses within a short time frame and 1 email going out, I think was all that came in, is a pretty good response. So
We just didn't have a lot of time to
actually utilize these services.
Right, to work on it.
I would just like to add experience from my region. It's not that I have had the problem myself, but I know some of the midwives in my area have, in getting prenatal testing, diagnostic testing. I took a copy of the new law to one of the perinatologists, who is one of the providers at that perinatal diagnostic center, and said, could you please read this and take this to the people who are in your group so that this can get fixed, because we now have this legal right. He said that he would do that. I followed up with him, and he said basically they decided to put their head in the sand, and that they are not going to do anything about it. They're not going to move forward with welcoming us to send and refer our people there. And that one of the reasons that he gave me is that because there's no hold harmless clause in AB 1308, that those providers who are going to take on the referrals and the diagnostic testing are not being held harmless for the care that they provide, given that it's the licensed midwives who are the ones who are going to be following up on it. So his feeling was that there was no way that it was going to move forward until and unless such a determination was made in law.
Seems to me that at the visit, the physician has every opportunity to talk to the woman and tell her what he thinks and give her his recommendations. If she doesn't choose to follow them, that's not his fault, is it? I mean, that seems like a ridiculous
The
comment.
interesting part about this is that this happens to be a physician who's pretty supportive of home birth, is incredibly supportive of the midwives in our area, and himself was born at home.
I just don't see how it puts him at risk, any more than it puts him at risk if Dr. Gregg refers somebody to the perinatologist here.
All I can tell you is that this is likely going to be a problem at places throughout the state.
It will, and as if you remember, we tried to.
You got to use the mic. I'm sorry, Dr. Gregg. Being recorded.
I can understand where that's coming from in the law. We tried to put some legal protections for physicians, and they were the first thing taken out, not by y'all, but by the attorneys. And so if there's anything that goes wrong with that pregnancy, the perinatologist sees themselves as the only one that holds the malpractice insurance, and they will be the ones that are gone after.
This is crazy.
I get it, unfortunately. Ms.
Rosanna Davis, California Association of Midwives. Before the medical board did their survey, we also initiated a survey so we could report back to the MAC about these issues. And we received several, and they were specifically about this ultrasound issue. Our survey also included contact information for the services that are refusing to provide the care. Do you want that information?
So,
Would you
yeah,
like it
okay, so
forwarded?
that's exactly, if you, and that was where I was going to go with, on the survey. If there was a way to find out from the survey where these services were not being provided from, and since you have some opportunity for some, there has to be some kind of follow-through. I mean, we have, the law is the law, and you don't have the opportunity, in all due fairness to whoever said what, to follow whichever part you want. The law is the law, and I think, in all due fairness, if we don't take any action and suggest to these people nicely that this is the law, and we've heard that there's maybe some misinterpretation. I mean, go on the opposite. Don't say you've been bad and we're going to shake our finger. There may be just some misinterpretation. We want to clarify for you. Here is the law, and if there's any questions, feel free to call our Ms. Lowe. I mean, we can't.
Awesome.
You know, I'll tell you, permission, authority is what you take, is not what you're given. So, you know, guys, it's easier to ask for forgiveness than permission. So it's my suggestion that this is that you can only fix a little bit. So let's try and fix what we can fix and not worry about let's worry about everything. But at least let's fix what we can fix.
If we can provide outreach to those 6 or 20 or however many it is, hopefully it's minimal, then it resolves this and we can move forward. So if you want to provide that to me.
What's the communication stream then? Would you like me to directly pass them on to you? Okay.
And I would just like to add that I'm heartened by the low number of responses that we're getting, that this is being a problem. But until we get to 0, I'm not going to be happy. The midwives in California have to be recognized and respected to be able to get these tests and diagnostics done. And until all the midwives in California have the access they need for their women, it's not okay.
It's not only the midwives that need the access, it's the families that need the access. Okay, so I apologize.
Yeah.
Yeah. I mean, it's about providing safe care to everybody in California, not just those who've chosen to use an approved care provider.
Midwives are all women too, aren't they?
So if there's no other questions on the survey findings, I'll go ahead and move on. But again, we'll redo the survey in some form prior to the December MAC meeting.
Great, thank you.
All right, so 8G is a regulatory update. We've pretty much discussed all of our regulatory updates throughout this meeting, but I'll briefly go over it. The next few months, we're obviously going to be very busy here, board staff and legal counsel. There's several regulations that will require Section 100 changes, which are simply regulation requests to clean up language pursuant to the new law. So it's just cut and dry, making it match up, cleaning it, not changing anything. We'll be holding the interested parties meetings between April and August to obtain feedback on several items, which we mentioned throughout the meeting today, on data elements provided on the transfer reporting form, data elements collected for the LMAR, and also regarding BMP code 2507 B1AI, which will need further definition. That's one of them. And then again, following all of the interested parties meeting, if we combine it into 1 or 3, it's not been determined yet. We'd like to get the most bang for our buck and get as much information as we can. Following those meetings, staff will start the process of drafting language for approval and go from there. We'll also be drafting language for Reg Section 1379.15, which will need to conform to the changes regarding the challenge mechanism. Regulation Section 1379.31 will also require changes when staff is able to determine whether or not C&M licensure is a viable method and so on. So those are possible reg changes that we'll be looking into. And we're hoping to be able to bring drafted language back to the MAC so that it can be presented to the full board in October. So we'll be working diligently to get the interested parties meetings done, as well as draft language to get back to the MAC in August. Does anyone have any questions on the update? All right.
All right.
Okay.
Any
public comment?
Public comment.
Public comment? Nope. All right.
Okay. I'm sorry.
So now we get your update.
All right, so I'll move on to agenda item 9, which is our program update. First of all, in the program update, I'd like to advise you that we have hired a new midwifery analyst for the medical board finally.
Yay!
Anna Marie Sewell is here with us today. And yay! So she will be handling the midwifery desk. She has worked for the medical board for several years now in the physician and surgeon licensing department, so she has experience reviewing applications and applying the appropriate laws and regulations, and I'm very happy to have her. She'll also be responsible, though, for handling outpatient surgery settings program and the polysomnography program, so she's not solely focused on the midwifery program.
You don't want us to overburden her?
I'm just throwing that out there, so you can.
Outpatient surgery centers can take 110% of her time.
Right. So.
How do I get her email?
I can provide you all with our email. I'm very glad to hand that on to you. So, all right. I'll move on to the Breeze update. So, 9A is the Breeze update, and just a quick reminder that Breeze is the Department of Consumer Affairs online license system that is used for internal processing of our applications, renewals, issuing licenses, as well as an online site that consumers can verify licenses and file complaints. Currently, the midwifery initial application is not available to be completed online, nor is the online renewal available. They are currently included in Release 1.2, which in common language is planned to be August of this year. However, prior to releasing these applications and transactions onto the online system, they have to be tested by board staff. Based on testing, if the applications do not meet our requirements, they could get pushed out to a later release date if they're not able to fix the issues that we have with those in time to get into the release. Currently, like I mentioned, they're scheduled for August. Those release dates are changing regularly. So it could be August now and could get pushed back, or could even get moved forward. They've mentioned breaking up the releases into smaller sections, so multiple items could get issued throughout the time frame. But as of right now, all I have to say or go on is possibly in August those will be online.
Okay, so I have a question, Natalie, because last time I thought you told us that renewals were sort of going through Breeze and that there were some hangups with that.
So
But now I'm
renewals,
hearing they're not in.
Okay, so for Breeze, there's two different sides of it. There's the VO, which is the online system, and then there's VR, which is our internal system. So we are using the internal side of it to process renewals and generate renewal forms and generate those deficiency letters after we receive the renewal.
Okay.
But the actual
online yet.
application for a licensed midwife to go on and renew and pay by credit card is not available at this time. So with that said, I have seen some improvements to the system, which is including the renewal forms are being generated correctly. Prior, staff was having to go through every single renewal form to ensure that they were correctly generated and had the correct information on it. So this, I'm hoping that we'll see the impact of that in the first week in April when the renewal notices would be generated. Staff feels basically that at this point any improvement is a definite positive and will save staff significant time. As we continue to utilize the system, as issues arise, we are still reporting those changes and those requests for changes to the department, and we're working with the department and the vendor to come to a solution on how we can get those issues resolved. It is a very time-consuming process and takes a lot of energy on our part, but down the road, it'll definitely make for a better system. So we're doing what we can to improve it. That's all I have for the Breeze update, if anyone has any questions on it. Okay. Moving on to
Public comment?
Is there any comment on this, on Breeze? No.
Okay. 9B is the licensing statistics. First, I'd like to publicly mention there was an error on the original document that was provided in the packets and online, and that the data for the fiscal year was not updated to reflect the second quarter's information. So that's since been corrected. There's copies provided to you, and there's copies provided at the back table. So.
Hard copy?
Here.
Okay. So one of the issues that we're still facing with the Breeze system is the inability to obtain statistical information from the system. Our IT department has been working diligently to extract data from the system and create required reports that we need. However, it also is a time-consuming process, so we're not there yet. We're working on it. There are reports available in the system, I will admit to that. However, we generated those systems for our data elements, and the numbers do not appear to be accurate. So we cannot rely at this time on the reports that are in the system. And so we're working to get those corrected and figure out what data elements are pulling to obtain the data.
Ms. Lowe, do we have a current number of active licensed midwives?
Those are one of the data elements that are not available.
Got it. You said that, didn't you?
It's okay.
I was thinking the question, I just didn't ask it.
So basically for licensing statistics, the only numbers that have been provided this time are applications received, applications pending, and applications or licenses issued. And that's because I've manually tracked those numbers when an application comes in and so forth. But as of how many licensees were in a current status at the end of the quarter, I couldn't tell you. Same way with the renewals. We have an idea, but we can run reports based on how many renewal transactions we process, but we can't determine what quarter that it was done in. It's only when that transaction. So we're working on getting you accurate statistics, and I'm hopeful to have something by the August meeting that not only will we have statistics for all of the required fields, but also for the ones that we can go back and get a snapshot for the quarter, we can provide those to you as well for anything that we've missed today.
Do you have a most recent number? Midwife LM 379?
The last number that would be, for
the most recent one issued?
It's approximately something.
Approximately?
It's approximately something.
Yeah.
I don't have,
Not even that.
I don't have that number. I mean, I don't want to throw a number out there, but the statistics provided on the report that show the last quarter's data is the closest that we can get at this time, and that was, I believe, at the end of September when we transitioned to Breeze, so.
Okay.
Okay, so moving on then, if no one has any other questions.
I have one about the website and getting to the license lookup, which at this point is connected to Breeze, which is, it seems to me that it's not easy to find. It used to be that, it seemed to me that it was much easier to go to the website and find the midwives page, where on the main website page now, there's, on the bottom right-hand corner, there are a couple of professions listed, but midwives aren't on that.
Okay. So on our homepage, I believe there's still a link on the right-hand side that says verify a license, and when you click that, you have to scroll through some informational instruction, which helps you get through the Breeze system.
Yeah.
So you scroll to the bottom and then select verify a license, and then it takes you into the Breeze system, which you can verify from there. But everyone's together.
Page.
All of the license types are together in the Breeze system, so you are selecting it by medical board, or you can select by name, or you can select a license number. So
Karen, I think what you're talking about is actually like the licensed midwifery page. So what we've done is we've revised our current web page, and we wanted to give everybody basically do right. So now if you look up at the top, you'll see consumers, licensees, applicants. So if you click on licensees now, it's not just physician. It used to be very physician and surgeon heavy up there. So what we've done is you click on licensees, now it goes to physician and surgeon, midwives, polysom, RDO, et cetera. So your page is now turned into the licensed midwife page under all of licensees
Not an
as well as
allied professional
Right,
anymore.
right. You're under the board. And
Right.
so, and then the same thing for applicants. You go to applicants if you're a licensed midwife, and now you'll see physician and surgeon, licensed midwife, et cetera. So that's where you're talking
I know,
about,
and I
think.
found it there. My issue was more if there's a citizen who's trying to find it, it seems like there are hidden, if somebody goes to consumer, it doesn't send them to physicians or midwives.
No, that's where Natalie was talking about. If you want to verify a license, everybody's the same. So you have to go under that
But even
path.
for the whole page. So if a consumer wants to go onto the medical board website and find the polysomnographic page, the consumer is not going to find that under
They
consumer.
would go under either applicants or licensees
licensees.
and see the license, the
Yeah, they
page.
just wouldn't know to go there if they're a
Yeah.
consumer.
They have to know to go there.
Yeah, or they use the A to Z index, correct.
And this is
for
important
Polysom.
because now we are required to give everybody the website and the information that they need in order to find us and our license numbers.
Yeah, and that's, again, under verify a license. Yeah.
Okay.
Great, thank you.
Thanks, Kim.
Okay, so 9Cs are very brief, as you'll see on in your packets, that for the enforcement statistics, we don't have any to provide to you, and that is not because there has been no enforcement action. It's, once again, that we are unable to obtain those statistical numbers out of the Breeze reports that we have available, or that we're in the process of creating our own reports to pull specific information. So again, at the next meeting, I'm hopeful to have those numbers to report back for this period as well as for the current period that we'd be reporting on.
Great, thank you.
Okay. 9D is the NARM exam. A brief update on that is that the medical board proctored a NARM exam here in early February. There was 3 applicants for the exam that sat for the exam, and in documentation provided by NARM for that exam, they did mention that they anticipated that that would be the last examination that we would be proctoring, as they're anticipating going to an online system at the end of the summer. So it's not finalized. They are working on that. I did speak with Ida yesterday at NARM to confirm, and that's in the process. So point forward, they would be, by the time the next exam came up this year, they're hopeful to have it as an online system.
So by August then. Great.
And that does conclude my update. If anyone has any
Are
questions.
there any questions or comments on Natalie's update? No? Okay. I need to revisit the working on the LMAR. Can I do that? Can I go backwards? Okay, good. So I'm going to appoint a task force of Ms. Ehrlich and myself to figure out exactly what needs to be changed and how we might best change it. And then we can work with staff that, like the coders, right?
Right. We would like to work with you on the task force and figure out what you are needing and what you're wanting, and then be able to then translate that to our programmers. So,
So the answer is you'll work with them and they'll.
Right.
Exactly.
So can we?
But we have our
will
own
be able to-
programmer.
Right, I understand that. Will we be able to speak directly with the programmers, I think is my point, so that
Yes.
nothing gets lost in the
Yes.
translation?
And between us and our programmers, I think we're quite capable of getting it to where you want it to be, because the actual requirements are, I'll just leave it at that.
Thank you.
We'll open that back up.
Okay, do I need a motion for that?
No, you don't.
No.
Okay, so we're good. So, all right, any further?
Yes.
Yes.
I'm in love with this 1985 newsletter that I've been referring to for a couple of years. What brought this to us today?
Unlicensed
It's
health
with the,
occupations
I know,
you
but
have?
it goes along with the assistance issue.
The what?
Because we asked staff to do some research on what was okay and what was there something that had been printed before by the medical board that delineated a little better what what was strictly crossing the line and what was not.
Right.
And the practice of medicine. So that's the document.
I know.
What's scary is I know some.
May we rely on this until there is further information?
Yes. I don't think you need to be relying on a document from 1984 because of the guidelines and that are.
No, we're
in
talking about
place.
for assistance.
I think we're off our agenda point now.
Yeah.
Your agenda is you need to
Along
call
with
for.
that, but we
for-
forgot
We are, but it was, this was given
forgot
to
to
us as part of
talk
the
about it.
paperwork for today, and it was never mentioned. It was
It's not
never
on your agenda.
brought
It
up.
was part,
It's part of the assistant agenda item.
Well, that was item number 5, about a half an hour ago.
Yeah.
It didn't say that on the corner.
Yeah.
Doesn't
Well, it
matter.
wasn't in our packet. And
So
so
you-
I was a little bit confused about it also. But I'm glad we have it now, and I'm going to take us forward. So we need agenda items for the next Midwifery Advisory Council meeting. So we're going to review the Midwife Assistance Task Force, the LMAR Task Force. The interested parties meeting should happen before that on the LMAR data points, correct? We need an update on these regulatory changes that you sort of delineated a few minutes ago. We should know by then whether or not the board accepted the changes to the standard of care to make it practice guidelines, so we could have that update. We need an update on the materials to give the board, which weren't completely fleshed out today, the comparison between CNMs and LMs, and I think that there will also be some additional information to go with that. Anybody have anything that I forgot?
You know, if you come up with something else, you'll add it. It's okay.
I suppose.
Did you mention your update on the MA task force?
Yeah.
yeah.
Okay.
Yeah, it's there already. You already put it in, update on Midwife Assistance Task Force. And don't forget to give everybody their little forms for travel stuff. All right. Nobody has anything else? All right.
Well, I just have a question. Is there still, I know it's not probably on paper, but is there still a action report?
Yes. It's called the newsletter.
Yeah. It's
I think that the medical board newsletter that comes out every 3 months?
Quarterly.
Quarterly, is the offshoot of this. This was a predecessor to the newsletter.
This has been renamed. If you go onto the board's website under publications, it includes all of the newsletters dating back to 1970s, I believe.
Okay.
All the way back to. Were
Sorry.
you born then?
No comment.
I was. I didn't think it was so long ago, personally.
Sorry. No offense.
I thought they,
All right. So if there's no more further public comment or business, I'd like to entertain a motion to adjourn this meeting. Do I have a second?
So move second.
All in favor?
Aye. I don't think you need a motion to
Abstentions
adjourn.
or declinations? No.
What do we have? What do we have
This meeting is now adjourned.